Editor-in-Chief of Health Affairs, and welcome to the unveiling of our thematic issue on health information technology. It's been an exciting morning around here. Some of you may have experienced the fire drill a few moments ago, followed by the arrival of the Public Transportation Association meeting. Speaking of a national infrastructure that needs work, we're happy to see all of you and that you made it through the long lines out front. I apologize for that confusion. Our thematic issue on health information technology was conceived of more than a year ago in an environment obviously very different from the one we have today. An environment where, of course, everyone understood the remarkable potential of all forms of health information technology to transform the health system to one that improved quality dramatically for patients, delivered far better outcomes, whether through electronic health records, computerized physician order entry, personal health records, all kinds of possibilities for transforming healthcare. But of course, much remained to be done. President Bush's call for a nationwide system of electronic health records, or a nationwide electronic health record system set of connections is probably a better way to say it, by 2014 was an ambitious call, but still appeared elusive a year ago. Only a minority of hospitals and doctors, as we know, had installed electronic health records. Agreements were poking along in the realm of standards and interoperability. Privacy issues appeared stuck in the mire of competing claims. And there was debate, of course, over many things, including whether we needed a massive federal investment to spur along the development of health information technology. Well, it's a year later. Developments since bring home the truth of two old saws. First of all, if you're in the publishing business, life is what happens when you're making other plans. Secondly, the other old saw, be careful what you wish for, it may come true. The passage of the American Recovery and Reinvestment Act, with its high-tech provisions on health information technology, have, in one sense, only reinforced many of the issues that we focus on in our thematic issue, but they've also raised a host of new challenges, all of which we believe will be the subject of our briefing today. With more than $19 billion now on the table for a variety of interventions, grants to hospitals and doctors, $2 billion in research funding, support for regional health information organizations, and for new regional extension centers, new privacy provisions that are yet again a subject of debate, and much, much more. Much, of course, remains undecided. Many decisions are clearly going to be devolved over to the Office of the National Information Coordinator under the Secretary of Health and Human Services. Many, many challenges lie ahead, and we're delighted that we were able to bring out a web cluster of perspectives from a number of individuals, including the former Information Coordinator, David Brailer, just yesterday, which enumerate many of the challenges that will be facing us in terms of implementation of high tech. Today, we have a number of our authors and other panelists with us to talk about their papers, obviously, but also the new challenges and new opportunities that lie ahead of us as a consequence of the passage of high tech. We will move through four panels, as you see on your agenda. First, several of our authors and our issue advisor, James Walker from Geisinger Health System, will talk about some pioneering initiatives in health IT, both at the health plan level, in the case of Kaiser Permanente, and in community settings, in the case of both New York and Massachusetts. We will then move to an industry perspective with, again, one of our authors, Peter Neupert from Microsoft, and then several other industry representatives, Colin Evans of Dacia, Alfred Spector of Google, and Neal Patterson of Cerner. We're delighted to have all of you here to give us the industry perspective, both on our issue as well as on the challenges that lie ahead. We'll have a discussion on health IT and privacy with Deven McGraw, another of our authors, and with Deborah Peel, who's a patient privacy rights advocate. And then we'll close with a public policy discussion on health IT after high tech with Robert Kolodner, Office of the National Coordinator for Health Information Technology, the David Brailer's successor in that position, and then several other individuals, Mark Smith of the California Healthcare Foundation, Carol Diamond of the Markle Foundation, and Jonathan White of the Agency for Healthcare Research and Quality. We are delighted to thank those last three individuals for the support they gave Health Affairs to produce this thematic issue, ARC, as well as Markle and California Healthcare Foundation having helped us to fund this. Just like getting to a national health information network, this is going to be a long, hard slog. We have not programmed in a break for the morning, so we encourage those of you to take self-induced breaks if you need them. Otherwise, we're going to move on through the morning. Let me start by introducing our first panelists. And I'll introduce them all now in sequence, and then they will get up and speak in sequence. First of all, we're delighted to have with us Louise Lang, who's a consultant with Kaiser Permanente. She's a physician. She speaks, writes, and consults on a broad set of healthcare issues, including electronic health information systems. From 2002 to 2009, she served as Senior Vice President of Quality and Clinical Systems Support of the Kaiser Foundation Health Plan and Kaiser Foundation Hospitals. Kaiser Foundation authors have two important articles in this issue, and Louise will present about those. We will then move on to hear from Dr. Farzad Mostashari, who's Assistant Commissioner for the Primary Care Information Project at the New York City Department of Health and Mental Hygiene. He's a lead practitioner and convener in the use of health information technology for public health, and is Assistant Commissioner of the Primary Care Information Project at the New York City Department of Health and Mental Hygiene. This is the nation's largest EHR extension project, and it has so far brought more than 1,000 New York City primary care providers at small practices, hospitals, community health centers, and even a correctional facility to participate in a prevention-oriented electronic health record. He'll be speaking about his paper on experiments underway, obviously this one in New York and in Massachusetts. And then we will hear from our issue advisor, James Walker, the Chief Medical Information Officer of Geisinger Health System. He's a leader in electronic medical record implementation and web-based patient information systems. Currently, as I say, the Chief Medical Officer at Geisinger, where he has executive responsibility for the multiple clinical information systems, including Geisinger's integrated outpatient and inpatient electronic medical record and library services.
Good morning. It's with great pleasure that I'm here to highlight some of the work that we've been doing at Kaiser Permanente. In 2004, George Halverson, the new CEO, asked me to begin overseeing the deployment of an integrated electronic medical record to cover our entire continuum of care. It was done as a strategic investment with the fundamental goal of transforming how healthcare is delivered, making it higher quality, better service for our members, and ultimately more effective as well as more efficient. In case there are some in this room who don't know about us, I have our statistics here. We take care of 8.7 million members, and we both provide care as well as pay for care. We have roughly 14,000 Permanente physicians whose clinical practices are exclusively with us. We have 165,000 employees. We work in the 9 states plus the District of Columbia. We own and operate 36 hospitals and medical centers, over 400 offices, and our last audited financials in 2007 were roughly $38 billion. We now have completed the outpatient medical record as of April of 2008. We have 23 hospitals completely wired with the integrated suite connected, obviously, to the outpatient medical record, but to all of our other legacy clinical systems as well. We have almost 3 million members of our 8.7 actively using My Health Manager. If you take the subset of patients who are over 13 and have internet, we now have 47% using our services. That resulted in 2008 in 6.1 million emails to our providers. That's 500,000 a month. We had 5.6 million prescriptions refilled online and 16.8 million results from labs were viewed. But deploying the health IT is only the beginning. And I think that's one of the messages that you'll hear from many of us today. Following the actual electronics, it's absolutely requisite that there be fundamental workflow redesign to achieve the value that we're all seeking. And that requires significant changes in healthcare team behavior and work, as well as, obviously, extensive involvement of patients. What that will do, in our two articles will demonstrate that, will decrease unneeded, costly services and decrease inefficiency. That freed capacity must be redeployed towards the other aspects of healthcare that are undermanaged and are achieving poor results, such as those in chronic care management, known population management prevention, and increases highly needed in both patient satisfaction as well as clinician satisfaction. You've all heard about primary care shortages, et cetera, and this comes from fundamental dissatisfaction from their current practices. So our first article, Transforming and Streamlining Modalities of Care, studies the impact on the Hawaii region. Hawaii has roughly 225,000 patients. It was our first region to deploy the outpatient aspects of the medical record. And we used a baseline year of 2004 and a comparative year of 2007. Fundamentally, across the entire region, there was a 26.2% decrease in office visits. It's roughly slightly higher in primary care, 25%, specialty care, 21%. The difference in numbers is attributable to the fact that the total office rate includes visits such as physical therapy, et cetera, that do not necessarily fall in either primary care or specialty care. Scheduled telephone visits, and I underline scheduled as opposed to simply telephone calls, increased 8-fold, secure messaging 6-fold, and yet, at the same time, total patient contacts comprised of telephone, secure messaging, and office visits increased 8.3%. We also tracked our HEDIS metrics, and even though there were no statistically significant changes, roughly 16 out of 22 metrics trended upwards. We also have data from other areas in which we believe both quality and member satisfaction are increasing. The second article is If You Build It, Will They Come? And it describes our experience across our entire system, all 8 regions of 8.7 million members, of the uptake of the secure message features along with all the other PHR functionality that we deployed most widely in 2006. Some features had been available before, such as online prescription refills, but many new functionalities were possible and deployed beginning in about 2006. Because one of the fundamental questions has been, will patients, in fact, use the features, and will they be not only able but willing recipients and participants in care? And I'm happy to say that the response has been overwhelming. In 2004, there were 10.7 million visits to our site called My Health Manager. And when I say visits, this involves or requires some interaction by the patient with various features. So in the beginning, we had 1.6 million prescriptions filled online in 2004. There were 726,000 visits to our health information site, Health Encyclopedia. Over the course of 3 years, these volumes have roughly tripled. So we now, in 2007, had 33 million total visits, which has risen again a comparable amount in 2008. We had 4.5 million prescriptions filled Again, in 2008, that's risen to 6.1. We had 3.1 million health encyclopedia visits, 10.2 million lab test results viewed, and 3.6 million secure emails to MDs. The last two, the lab results and the secure emails, are new features. And so there is no baseline for 2004, for instance, for secure messaging. As I mentioned, in 2008, that volume went from 3.6 million to 6.1 million. And we believe that this will continue to rise. The other thing is that there was an assessment in the second study of usability versus usefulness. A lot has been focused on the usability of various websites, healthcare ones as well as other ones. And what we found is that the overwhelming factor of adoption has to do with usefulness rather than usability. Now, obviously, you have to have a certain amount of usability, but that what really brought members to the site and brought them back again was the ability to contact their healthcare provider, to better understand and manage their health, and in fact to have enough information to make informed decisions. So our message is, from these two studies and a lot of other assessments that we have done, is that broad implementation and use of a combined EHR-PHR is very well received by both healthcare professionals and patients due to perceived and real value. That unnecessary and marginally productive office visits are reduced or replaced with telephone visits, secure email messaging, and, in fact, other aspects of the PHR, while maintaining, and we believe over time we will demonstrate, improving quality and satisfaction. However, there needs to be both investment in and work on fundamental redesign of the daily work processes in healthcare delivery as it's currently being delivered. And in addition to that, obviously, Kaiser Permanente has the right financial incentives to, in fact, move to better quality, more effective, efficient care, but many parts of the rest of the system do not. And this needs to be addressed both in terms of the initial investment, but more fundamentally in terms of the ongoing reinforcement. Thank you.
Thank you. I'm representing the New York City Department of Health, and the paper that we wrote with Mickey Tripathi, who leads the Massachusetts eHealth Collaborative, the challenge that we took was to pick up the gauntlet where Louise left it, to say we clearly need fundamental redesign of work processes and the financial incentives to make those sustainable. It's clear that integrated delivery networks have been able to do amazing things because their financial incentives are aligned and because they have the workforce and the savvy and the technology to be able to implement those changes through health IT or enabled by health IT. The challenge we took was, how do we extend that model to hundreds of independent practices, small, medium, and large, within a community? Is it really feasible to get deep penetration of health information technology and the workforce changes that are required in a geographic area? And our paper basically describes two examples in Massachusetts and in New York City where we were able to accomplish that. David Blumenthal, in a Commonwealth Fund report released recently, said, obtaining real value from unprecedented federal investments will require local support organizations that help doctors install these systems and use them meaningfully to achieve improved quality, efficiency, and continuity of care. And so that, I guess, is the challenge. How do we set up these local support groups where they don't exist today? Fortunately, the American Recovery and Reinvestment Act provides for the creation of such support organizations, so-called Regional Health Information Technology Extension Centers, RITECs. It further provides state grants to encourage providers to work with these support organizations. It includes, under allowable costs that would be reimbursed under the Medicare and Medicaid incentives, for those types of support services. And importantly, in the Medicaid section, some of the upfront costs could be used and directly routed towards these so-called RITECs that could serve as group purchasers for services and software. But if we want to achieve the real potential for these RITECs, we must demand that they not just demand but also empower them to have certain characteristics. First, they have to be accountable. Someone has to be accountable. In my project, it's clear I'm accountable for how successfully we get adoption and meaningful use in New York City. We have metrics, we have utilization data, and we track them over time. And if we're not able to hit those targets, I'm accountable, and I can be replaced. The second thing that it does is that it helps distribute the administrative burdens of monitoring and helping to improve practices' ability to reach meaningful use. And importantly, we can be accountable not just for adoption, but also getting some of the public benefits that we expect from these projects. Next is effective. You know, there's the old saw about a third of all IT projects fail. We have a 99% implementation success rate. And these are not early adopters. These are, poor practices struggling in the city's poorest neighborhoods. We have 53% of all small practices in Harlem, the South Bronx, and Central Brooklyn who are now in our program. So we've been able to act basically as the glue, the connective tissue. What KP does for their providers, we're doing for that storefront in Harlem, and we've been able to provide that end-to-end project management, troubleshooting problems, working with the vendor, being that intermediary, and assuring cooperation with third parties who usually wouldn't give small practices and sometimes medium and large practices too much attention. The third thing that community projects must be is innovative. This marketplace could really benefit from some disruptive innovation. But to do that, you need customers. You need good customers. You need tough customers who can ask beyond their, change this screen to suit my, doc who has a lot of influence in my system. It has to go beyond that. It has to say, we really want to make the process 10 times easier, not 10% easier. We really want to have new functionality. So Mahek said, we want different EHR systems to be able to talk to each other, and they forced their vendors, for the good of the vendors and themselves and the community, to be able to have real interoperability between those EHR systems. We had a different orientation. We said we really demand prevention functionality, integrated registry functions, quality measurement, decision supports baked into the system, and we were able to get it because we had the size and the sophistication to be able to serve in that role. Security is not a given. Just because the system has functionality, just because it has user-based access, just because it has password protection, just because it enables encryption, has relatively little correlation with whether it's actually used that way. So one of the things that we do is that we actually have a privacy lawyer who works with individual practices to implement the security provisions in the system, to use them to protect patient privacy. And being networked, not just networked in terms of health information exchange, and we all, I think, know that the standards and certification, though necessary, are not going to be sufficient to actually get information to be exchanged. We can provide the context within that to harmonize the local groups and to set up the context wherein information sharing actually makes a business case, and to standardize the implementations to support that interoperability. They also provide networking in terms of providers being able to talk to each other and to see how their peers are doing, particularly on quality measures, and provide an important motivation to improve. And efficiency. If we want to get the biggest bang for our buck from these limited dollars, it makes a lot of sense to pool not just our money, but also our implementation experts. The workforce limitations here are going to be quite significant, and we have a team of about 50 people who has helped 1,000 providers in a year go live on a system. So that's a pretty good use of a relatively limited workforce. And I think it's also critical that we be able to use the size and scale to obtain discounted pricing and higher level of service, more importantly, from vendors. In addition, we've been able to get additional support from state and local governments, from foundations, health plans, and others. And I think that's also going to be important to leverage. Just because the federal government has made this unprecedented investment, we shouldn't say everyone else is off the hook here, because there is not enough money in this stimulus bill to get it done. So in sum, we wrote a paper, and we had many of you here, but we had 50 co-signatories from 26 states right as the bill was making its way, finalizing its way through the Congress. And we wrote, community projects ensure that the implementation of electronic health records is focused on public benefits that might otherwise get overlooked. We fear, and continue to fear, that an historic opportunity to achieve quality and efficiency gains through health IT expansion will be lost unless federal strategy is grounded in the proven success of the community extension model. So the legislation is passed. We now move on to implementation. And I would say there are three things that we have to make sure in the implementation stage carry this forward. The first is these have to be set up aggressively and empowered. We're talking, I think, in order to meet the needs of, say, 200,000 providers who normally wouldn't be able to adopt purely on the basis of incentives without additional supports, we're talking something like 60 projects, each of which could do 1,000 providers a year, of that kind of magnitude. We think that with $25 million of core funding from the state, from the federal government with a 50% match, that could really be a sustainable structure. But that's a lot of money, and there are a lot of competing priorities for the limited appropriations in that bill. The second is that they need to be empowered as group purchasers. If they don't have the leverage of the contract, they don't have any leverage. So these groups must be able to directly contract for services and software. Finally, the existence of these community projects means that we can have higher standards and expectations around meaningful use. And I think that's going to be an important discussion in the short term, coming up quickly. And beyond ERA, I think we really have to think about how health IT can help enable the critical healthcare reform that is to come. Instead of just looking back at ERA and saying how can we best implement that, we also have to be looking forward to saying how can the new health IT infrastructure with the community supports help us imagine healthcare reform in a new way. Thank you.
Good morning. I'm a doctor who several years ago realized that if we didn't get to where we could use computers effectively, realized we'd never really get efficient, high-quality health care. I work at Geisinger, which is an integrated health system that serves a little over 30 poor, underserved rural counties in northern and central Pennsylvania. We have an integrated inpatient, outpatient EHR with a networked patient health record and a regional health information exchange, all of them linked to try to provide information everywhere it's needed to the right people to support patient care throughout that 30 counties. Our paper, From Tasks to Processes, addresses a problem with health information technology. Despite its demonstrable potential to improve care and improve efficiency of care, it's been hard to show in any systematic or thoroughgoing way that it actually does that. And there have been a number of very well done negative studies. And that raises the question, what's wrong? And we point in this paper to one of the things that we think is wrong, that health information technology has been focused on tasks, not processes. The classic way you see this if you read the literature is that the focus is on order entry, which of course is something the physician does in the moment, ignoring the fact that what is really the issue is order management, the negotiation between patient and physician and nurse and pharmacist and radiology tech on what's the appropriate thing to do and whether it's gotten done and what the outcome is and what the follow-up should be. So that what we often get with health information technology is one task done unconnected to anything else. What we obviously are all after is value-added care processes, where each step in the process gets carried out, and by the way, gets carried out timely and efficiently and in a very satisfactory way to patients and clinicians both, so that the result is high reliability, high quality processes that incidentally are much higher efficiency than has been the case in the past. An example of this is a woman whose time has come for a mammogram. That may be ordered, and the woman may never get to the mammogram site. If she does get to the mammogram site in a very large study, there's a good chance it'll be 11 weeks from the time she gets the mammogram to the time she sees someone in a breast clinic if that mammogram is abnormal. And of course, a fair number of women just get lost to follow-up altogether. So what we're after is creating processes that actually run end-to-end and using health information technology to support that. An example at Geisinger is open heart surgery. 7 CT surgeons sat down together, went through the literature, and identified 45 sub-processes, all of which they believe have been shown in good research to decrease the risk of a patient having complications with that open heart surgery. Then we measured how we were doing on completing every one of those 45 sub-processes for every patient that we did an elective open heart surgery on. And we found that appalling first number, which is even more appalling when you realize that's better than national benchmark. And what we did then was not get out the EHR, but redesign the process, all the way from the initial assessment in the family physician's office to the cardiology consult, to the pre-op visit in the pre-op clinic, to the surgery and all of the people in the hospital who need to make that process work, all the way to post-op rehab and continuing follow-up. Having built that process and changed, by the way, the task description of everybody related to that process, patients, front desk clerks, nurses, surgeons, cardiologists, family care physicians, then we built those processes into the electronic health record, and you can see the results. I put that last number in so you know we're telling you the truth. The process is not perfect, but it is obviously possible to make very dramatic changes in the quality of processes if we design them properly and then have electronic systems to support them. What is true about electronic systems is that they will not improve healthcare, but they are absolutely critical if we're going to improve healthcare. It just is not possible for a group of people to agree on how we're going to manage patients with diabetes or heart failure or who need a knee replacement, and then everybody be reminded of what that agreement is at all the appropriate points along the process so that the patient gets what is, to them, a seamless version of care. So, what do we need? Well, we need lots of things, and the paper talks a good bit about the evidence that improving processes really can improve care, and then some about what the basic steps involved in improving processes are. But one of the things we clearly need is interoperable processes. We talk a great deal about interoperable data, which we also need badly. We have to be able to talk to each other. But if we're going to achieve the kind of performance on the last slide anywhere except in integrated healthcare systems, we're going to have processes that are well enough defined that multiple stakeholders can participate in those processes and know when it's been initiated and what the next appropriate step is and when it's appropriate for it to be done, so that all the way along that process, people can take better care of the patient. So if you go back here, there's no reason that all of those green arrows have to be performed by Geisinger. Those could be shared by an outpatient physician and a mammography suite that's freestanding and a freestanding breast clinic. The only issue is that we need to all agree what the process is, that we need to agree what the interfaces between those processes are. Is the mammography suite, if they're going to get paid, are they responsible for reporting abnormal results within 3 hours to a breast clinic to get paid? Is a breast clinic responsible for having a slot for a patient available the next working day to get paid? If we design those processes right, it would be possible to have a rational payment system that would really achieve what we want, which is high quality and efficient and affordable care, in a way that would be fully accountable all the way across the system and not put any burden on small practices and small hospitals who can't do that yellow bar down at the bottom. Clearly, there would be groups like Hudson Valley and like Kaiser and Geisinger who have the ability to manage processes and could provide that service as another reimbursable service. So, we need to be able to have defined sub-processes, and we need to agree which ones actually add value to the patient and which ones we ought to quit doing because there's good evidence they don't do any good. We need to have defined interfaces between those sub-processes. We need to pay for them in a rational way. And then we could use EHRs in a way that would be hidden from patients and largely from users to really improve the processes of care.
Thank you and good morning.
Good morning.
Oops, it's going the wrong way already. I'm a software guy. And as a software guy, I'm really optimistic about what technology can do to improve health around the world. We set out an ambitious mission for the Health Solutions Group to think about how we could do for the health sphere. I like the health sphere. I typically call it an ecosystem, but sphere seems more compelling to me. As we did for the computer revolution in the 70s, 80s, and 90s. But I have to first start and agree with everything that James Walker said, that it's not about the technology. It's about the people and the processes. And our focus and our strong emphasis as people think about the policies that need to be implemented to make a successful infrastructure investment in health information technology is that we focus on the outcomes we're trying to achieve and figure out what the right technologies are to achieve those outcomes and not the inverse. Because we can invest a lot in technology, as James identified and others did as well, and not achieve the objectives of improving the lives of patients, physicians, clinicians, and our country. So I think it's really important that we think about how to structure our conversation and to keep the focus being on what are the right investments, where are the good returns, what are the simple things we can do. When you think about interoperable work processes, as a software guy, I kind of think about that and say, holy crap, that's going to be really hard to do. And in the meantime, there's a lot of really good things that we can do to get the ball rolling. And as happens so often in health, the perfect becomes the enemy of the good. And I really think there's a lot of good things that can be done right away, and that we should focus on doing those right away. When you look at where the costs are, 75% of the costs are in 6 chronic diseases in roughly 18% of the population. We had better focus on trying to improve those chronic conditions if we hope to get any money to save and invest in providing better access for all of our nation's citizens and in improving our infrastructure and cost system. In order to really focus on those outcomes, I think we have to be very thoughtful about allowing changes in our payment systems and aligning changes in our payment systems to support new ways, new types of innovation in what are the best ways to care for those chronic conditions? How do we incorporate data in the home? How do we incorporate the patient? How do we motivate and incentivize education and health literacy as part of the education and motivation, behavior change management, all the things that have to happen to manage these chronic conditions? So we need innovation on the supply side, the payment side, and we need innovation on the demand side in terms of educating and motivating our citizens, consumers, to better take advantage of those people that are supplying services that are good for them. So we need additional transparency in price, cost, as well as the technology that allows for the low-cost two-way communication enabled by the Internet. And I think there's lots of places where we can invest to get immediate return when we think about how to deal with these specific outcomes. So, step one, focus on the economics, align our incentives, align our consumers and our physicians alike. At Microsoft, we think about scale a lot. Our business model is very dependent on delivering scale solutions. We deliver hundreds of millions of copies of products on an annual basis. And when we think about building a scalable solution to health, we think about starting with the patient. What is a patient-centric way to really... Thank you. I think I'll sit down now. And we keep in mind, when we launched Health Vault in October of 2007, was how do we use the patient as an agent of change to try to connect the system, because it is about interoperability. It is about connectedness. And what can we do today to enable the patient to be an important part of that connected system? And we think there's three pieces to really building a scalable system. And first, it's a necessary but insufficient condition is to liberate the data. The data has to flow with the patient. There's lots of important medical data that exists today electronically and digitally that we don't use yet effectively. Medications list, laboratory information, image information. If we could just get those three things, yes, it'd be great to have problem lists. Yes, it'd be great to have allergies. Simple things. These are complicated to do technically, simple things to do effectively. We can do a lot to improve these chronic conditions and improve the care delivered to citizens. We need to empower users. When Farzad said, those doctors hate him because it takes longer, as a software guy, I say, unacceptable. We got to be able to do better in terms of delivering software. We need innovation in that user experience for those physicians. It shouldn't have to take longer. We have to fix that. So if it's not better for the physician, they won't adopt it. We can do better. We're going to focus on that. Importantly, left out is we need to empower the patient/consumer, and they need to have access to information so they know whether these interoperable processes are being handled correctly. I think patients can be very effective advocates, or an advocate for them can be very effective co-pilot through the system. So those are important things to enable the sharing of data to citizens, patients, and their advocates. And most importantly, we have to figure out how to connect care. Care in this country, and in most countries as I travel around the world, is delivered across organizational boundaries. Data doesn't flow very well across organizational boundaries. And the patient, perhaps, is the most important individual in the care delivery stream that will effectively be able to move data quickly and to ensure that they're getting the right care at the right time. So when we think about what this future looks like, it's a connected health system with lots of workflows and data flows between organizations that aren't of one single entity. And we think this is doable, and a lot of it's doable today. There's a big debate of, do we need more standards? Standards are good. Standards make life easier for software guys. Standards make life easier for people who are on the receiving end. Standards don't make it happen. Willpower makes it happen. And changes in alignment and incentives can make it happen. I don't personally believe we need more standards to make this happen. Today in the state of Wisconsin, we run a health information exchange. We connect about 25 clinics, 13 hospitals. They've determined to share a certain amount of ADT and laboratory information. We've connected the Medicaid claims database of 2.3 million members, and it works. We just made it work. You can make it work. Where there's willpower, you can make it work. I think there's been lots of demonstrations of that. We think with Health Vault, we can connect disparate systems. CCRs from one system, CCDs from another system, the workflows across. We can start to make that happen today. We don't need to harmonize standards. We don't need to create new standards. We need to work at making connections happen and motivating the interactions at the physician and the consumer level to do that and to do it now. To keep my remarks short, we think there still needs to be a lot of innovation. So as I encourage us to have the policy conversation, that we don't lock in the inability to innovate. We need more innovation in lots of different areas. And the funny thing about innovation is you don't know where it's going to come from. It's important not to lock it out. We need to think connected to the payment system. We need to reward doctors for doing the right thing. We need to motivate them to prevent people from coming in to see them in the office. There's a lot of things you can do to intervene in the home, to use electronic communications, as Louise demonstrated in the Kaiser example, to make their lives more efficient and patient lives more efficient. We need to reward them for doing it. We can remove the barriers for data exchange and create some incentives for data exchange. We need to liberate data and separate data from their applications. There's a challenge associated with companies' business models that makes it harder for people to share data. We need to change that. Companies need to compete. They need to compete on areas other than data lock-in. There's plenty of places to compete around user experience, about capability, about functionality, about price, about service, not about data lock-in. And as a vendor in the enterprise community and in the personal health record community, personal health data management system community, we promise that any data that goes into our system will get out of our system easily and electronically in a format that's usable for the receiver. And we need to enable the private sector to continue to work to connect the system. There's no one-size-fits-all. We need to figure out ways to continue to innovate in the connectedness to enable these interoperable work processes. I like that. With that, I'll finish my remarks.
Good morning. My name is Colin Evans. I'm here to build on what Peter was talking about. I think I was asked to talk about, what are we doing, why are we doing it, how are we doing, and what do we think about the stimulus bill? I think that was sort of the agenda today. So patient as an agent of change, I think, is the way Peter described it, and that's certainly what Dossier is trying to accomplish. We're an employer-led nonprofit trying to build a system that gets data in the hands of our employees so they can become that agent of change. We've got the companies here. You can see them represented. 3 different orders of magnitude of size of company, 10 to the 5, 10 to the 6, and 10 to the 7 employees for the mathematicians in the audience, ranging from, well, I want to explain that. Why are we doing it? I think the reasons that fill subsequent volumes of Health Affairs are the reasons we're doing this. The system that, as employers, as payers of healthcare, payers for healthcare for employees, we regard the system as inefficient, ineffective. Some would say unsafe, and it's certainly unaccountable. It seems to us that as the patients and the employers as payers of the system don't seem to really get the kind of accountability and responsiveness in the system that we'd like, and where to try and change that. It seems that the new administration has certainly got that bit between their teeth and would agree with this. This quote I took from the announcement that during the Sebelius announcement the President made. I think there's some agreement that with some of these facts. Although I thought it was interesting at the White House conference last week, just to kind of digress a little bit, of the people that were invited, leaving aside our elected representatives, who I'm sure are all completely independent, unbiased, and working on behalf of all of us, I'm sure.
We have a bridge we can sell you.
Exactly. Of the people that were invited, 35% of my quick check of the guest list, 35% of the people invited were from healthcare. Well, you'd expect that, I suppose, doctors, hospitals, insurance plans, and so forth. About 32% were from patient groups. You'd expect that. 6% of the people in the room were from employers. Only 5 people, and 3 of those represented small business. So the people who are paying for at least paying for half the system, don't seem to be at that table, and I think that's something we should think about if you're looking to reform the system. So we're trying to put ourselves, the employers, in a situation where we say we pay for the system, we'd like to get involved. What are we building? We're building a 3-layer cake here. Peter described many of the aspects of what we're trying to do, which is really deliver really useful, engaging tools and services to employees to get them involved in their health. Yes, chronic care is a big part of that. A lot of what employers spend their money on is dealing with the 6 diseases that Peter talked about. I sort of see people in little 2x2. People are sick or they're not, and they care or they don't. And from an employer perspective, capturing giving useful information to the people who are sick and they care is actually the low-hanging fruit, and really where most of the medical data is required. But the people who are not sick and do care is the other part of the low-hanging fruit. People who know they're overweight should stop smoking, should manage their blood pressure and cholesterol and so forth. Don't have a lot of medical data per se, but are very interested in getting involved in their health. That's sort of another big part of what we're trying to do. Not sure what we do with the people who are sick and don't care. I mean, that's a whole different marketing program for us employers. So we're, and this is a data-intensive but yet a data-protective environment. And to get the useful tools at the top of this picture requires us to prize loose data from the bottom. The healthcare system sort of works like as if you went to your broker and said, I'm your broker, but I'm not going to tell you what your portfolio is worth. I mean, it's that sort of a relationship that a lot of people tend to have with the healthcare system. Now, we'd like to get people the data that they're entitled to use and would help them care for themselves and their family. We've implemented so far with Walmart, not the ideal, smallest, because the largest employer in the country wouldn't be the natural test place for a system. We've implemented in Walmart so far. We're growing our adoption footprint and trying to take a lot of the lessons learned there and incorporating them into the other founder companies who are sort of in the flight pattern to land in 2009. If I go down, so why are we doing this? We're focused on empowering individuals. We think for 4 reasons. One is we think competition is critical. There is no market per se for healthcare today. We'd like to create one. You will not get change, whether it be at the employer level or at the national level, unless you get the patient to be a committed stakeholder in that environment. So connecting doctors through RIOs is all very useful, but if the patient doesn't know or care and isn't really actively trying to get involved in that, that's not going to be very useful. So, getting the employees and the voters involved in healthcare reform is critical. They need to be better informed to make better decisions. It used to be that decisions that people made, there weren't decisions. You took the pill, you had the operation, you lived, you died. That was sort of the sort of Marcus Welby era. I think today there are lots more choices that we expect people to make about their care and lots more choices that we expect doctors to help them with. And it's a very, as I say, an intensive information environment. Finally, however, I think even though the stimulus bill, which I'll talk about briefly in a moment, focuses on getting medical record systems in the hands of doctors, there is a ton of data today that is already available that can be extracted and put in the hands of patients. And I think it's something we tend to forget here, that to create those useful systems, most of the data that you need is actually available today, and I worry that that's getting lost in the current sort of reform discussion. So 1 minute comment on the ARA Act? Does it stimulate change? First and foremost, the most important element, I think, in the bill, which I'm sure others will talk about later today, is a patient right to their data electronically. HIPAA says you can have your data. I remember talking to some insurance executives a few years ago and said, what do you do when people ask for that data? And they say, well, send them to the basement. Was the sort of response I got. But the bill says that you have a right to your data, and you have a right to electronically, and you have a right for that data to be sent to a place of your choice. This is a huge step, in my estimation, towards data liquidity, the free flow of data, and put it in patient hands. Very important. There are sticks and carrots for interoperable EHRs. I'm sure we'll hear a lot more about that from Rob and others as we talk about. I would say that one of the key things we need to be worried about here is the focus on portability of information, and I fear, frankly, that a lot of that stuff has been lost in the way the bill is constructed. I'd commend you to read David Brailer's article that was, I think, posted on the web, which I think he poses the issues, I think, very clearly that we have to kind of worry about, I think, as the way this thing evolves. Will we build on existing standards? Will we leverage existing organizations? And have we really created an environment for innovation, or have we created a kind of Soviet system that tells you what system to put in over the next 2 years, unless you won't get paid otherwise? I think these are big questions that I think should worry us. Obviously, there's a fast track for HHS and FTC to create a lot of rules on a pace that is unheard of in political and rule-making circles. So I think a lot of us are becoming pen pals with the FTC on this topic. I know I am. And I hope to stay close to this. And finally, even though that the PHR systems don't become covered entities, certainly the privacy rules that apply that have been strengthened and created, on the one hand, should be good news for individuals and patients. And from a dossier perspective, we're certainly more than happy to, we kind of aimed ahead of the duck, and I think we're in good shape relative to the rules. I do worry about the tensions between portability and privacy. I think, David's quote was, this could bring our early experiment with information sharing to an end if we don't really carefully manage these provisions. So we're all about empowering healthcare consumers. We think there's that's a strong imperative for both government and employers, and I'll be happy to take.
So let me also address the points that we've been asked to do. So I will, in turn, try to talk about what we're trying to achieve, I think, relatively broadly as an industry with patient healthcare records and patient empowerment here. It is somewhat different and an interesting take on how we can move forward. It's a different thing than the electronic healthcare records owned by the establishment. Second, I'll talk about what we at Google are doing, what we see our opportunities, strengths, and challenges are. And then finally, I'll try to comment briefly on the impact of the recent legislation, on what we're trying to do, and what we think we need to do going forward. So let me just try to really focus on the consumer side of this, since so many of us here are from the medical establishment and from hospitals and other folks that are providing care. So we really do have the idea here that if the patient has information at his or her fingertips, that information is usable and is fairly, perhaps not perfectly, but fairly complete, the patient will become an amateur expert, if I can use both terms, sort of an amateur but somewhat expert in their own health, and contribute to their own well-being. And I think all of us know that if a patient has a good advocate, they get better care in our system. The patient can be their own advocate or have a sibling or someone else that can be their advocate. We think it's extremely powerful. So we're trying to do the things to enable consumer access to their health data. And health data comes from a variety of sources. Yes, it certainly comes from the physician, but it comes from pharmacies and it comes from lab testing agencies. There's no reason it doesn't come from insurance providers or the federal government that acts as an insurance provider through programs and the like. And it comes through an entire lifetime, and much of it becomes relevant over time and for many reasons. So to provide access is part of it. It requires broad reach. It requires consistent reach. It requires, I really like the comments from Kaiser earlier, it requires a useful system as well as a usable system. I love that differentiation. I think that's critical that everyone focus on utility as well as usability. You have to provide real value. Now, underlying it, you have to store and aggregate the data. There's a lot of it. There'll be more as we get increasingly into storage of all the image data, which we should be able to store for a lifetime, and there's more and more of that in genetic data, proteomic data. So we have to aggregate and store, indeed, with appropriate privacy protections, because that's necessary for many reasons here. And then we need to provide all the sharing that one can envision here. So it's sharing that the patient wants, though, in this take of it. It's not sharing that the doctor says should happen for the patient's therapeutic benefit. That's one model. That's a great model. In no way do we deprecate or denigrate or say that is not needed. That is clearly needed. The enterprise, as it's referred to, I guess, in HIPAA, is a necessary part of all of this. But there's also the side that the patient says, I want my brother to see this. I'm interested, my brother's a physician. I want my brother to see it. It's commonly true in my family. So we want that. And that's patient. My physician doesn't know that, doesn't need to know that. So the sharing is valuable. The sharing is also valuable at least for the ad hoc mechanisms to enable the patient to get information from one physician to another. Now, maybe in the fullness of time, the entire world is perfectly wired and all the systems are connected, perfectly. I think I'll be quite a bit older before that happens perfectly. So if the patient could say, hey, I think this is relevant, let me get that to you, it'll probably improve healthcare, probably reduce costs, and certainly keep the patient involved in his or her own care. So that's what we're trying to do in the industry. We think that's a valuable addition. And how all this will play out and the relative value of the different parts, I think, is unpredictable. This is a $2 trillion plus industry. It's hard to know, but it seems kind of crazy not to try this aspect of this solution to this problem. So that's what the PHR is about. Many of you know this. Perhaps those of you that don't, this was a worthwhile introduction. Now, why are we in it at Google? Well, I think two reasons. One is mission. The mission of our business has been to try to organize the world's information and make it universally accessible and useful. And it strikes us as clearly obvious that there's a lot of disorganized or unorganized healthcare information that's not anywhere near as useful as it should be. Secondly, we actually have an enormous number of technologies that can make things easy to do. So we have cloud storage, as it's referred to among the techies. So storing the healthcare data that we store today is a very tiny thing for Google, whereas for many establishments it would be a lot. We have an enormous amount of infrastructure to get to mobile devices, which will play an important role for consumer entry, for monitoring, and the like. We have security infrastructure, which is clearly needed to handle security and privacy. We have reach, so we can go after millions of simultaneous users if we are so lucky as to have this as prevalent as we want. And then finally, we have quite a bit of trust and current consumer acceptance. Consumers go and search the web to find out about their illness before they consult a physician an enormous percentage of the time. We've achieved a position of trust, so we hope to utilize that in trying to move this movement forward. So we launched the Google Health system in May, about, 9 months ago, approximately. It's a so-called non-tethered PHR because we don't have specific contractual relationships to be the PHR for a particular hospital or practitioner, but we can connect to them under the patient's at a patient's request. So a user controls and owns his or her data. It's interesting to me in this realm, and I want to emphasize that I would have thought it was clear to this community, but in discussions I have on a regular basis, it still seems to be not completely clear. The model for PHRs is that no one can authorize distribution of data from a PHR repository to anyone else other than the patient. So what a PHR really is an electronic notebook that the patient has about his or her health records over time. So I have a notebook. We all probably do have some paper still. That's what this is, but now in the electronic form. And now what a patient does with that is up to the patient. There is nothing that we could do to preclude a patient from posting it on a website. If they thought that was useful to make a statement about their illness and the importance of research in it or whatever, that would be permissible. A patient could authorize that, or a patient could decide they're quite private about things. But it's the patient control. And I'll get back to this whole issue when I talk about privacy in a minute, because it's rather different than what the consumer or patient expects of the medical enterprise, where the medical enterprise must maintain the confidentiality since it does not know the patient's wishes. Our system is free to users and partners. We've done that, not that we couldn't consider advertising, but we're trying to gain trust in the system, and we don't want this confused. We integrate with others at users' requests. And the very interesting question that comes up that all of us in this industry think about is, in terms of providing utility to the user, how do you interpret information to the user? Now, this is a very interesting question. Do we want to interpret information? Well, there's certain things we can, right? We know 98.6 is a normal temperature in Fahrenheit, so we probably could say that and get away with it and not have too many people disagree. On the other hand, there are many things that if we said, there would be substantive disagreement in the healthcare profession. So I think the only model that tends to work here is that the data has to be made available at patient request to interpreters for more complicated interpretation. I think the industry believes that. So there can be decision support tools for consumers that provide some degree of understanding about the patient's condition. And there may be competing ones. They may come from different perspectives because exactly what the nature of truth in this industry is not exactly clear. So that's the notion of add-ons. And Google integrates with, plus or minus 50 parties today. We have a long way to go to fulfill the vision. Now, so what about the stimulus here and us? So there is a lot of data. So I do agree with Colin. There is a lot of data today that is available, particularly, say, for example, pharmaceutical prescriptions. There's a lot of that, a lot of test data. There's a lot of data that's missing. Clearly, there's insufficient data to do everything we want to do. Lots and lots of individual physicians, as we heard from Farzad, do not have access to EHR technology today. There are incentives to get more into electronic format. So we think that's going to help in the PHR approach because we cannot expect consumers to enter lots of complicated stuff themselves. Second, patients getting their data is opt-in. Well, that we expect to be and not mandatory. However, and we don't want to change that. We don't want to have every patient be forced to sign up for a dossier or Health Vault or Google Health. That's not something the government should in any way be doing. We would certainly not want that. However, covered entities maintaining EHRs will be required to give copies of medical records in electronic format as part of this, at least as we read it. And that's a good thing because we think that a valid thing for consumers to request is to request a copy in electronic format for their PHR and to have it sent to some system where it can be maintained with integrity and availability, universal access, and the like. Third, there have not been real incentives for payers and providers to open up their data silos and share data. There appear to be incentive payments to require EHR so that do data exchange and connect to HIEs and the like. So I think this whole sort of the whole ambiance of this bill says, look, we cannot have individual silos. This is an integrated healthcare system. So many aspects of the bill talk about interoperability that I think we have to recognize institutions, software vendors, all of us can't say that they are the Roach Motel of data, if you will. The data gets in but can't get out. We don't want that here. And then on the standards efforts, while Google, if any company, has shown you don't have to have perfect standards for everything in order to be able to organize data. Look at what we've done with just web pages. The more standards there are, the more semantics that can be applied uniformly, the better. So while we don't believe we should all go away for 7 years and let standards bodies codify and agree and create unions of other standards and build edifices of paper that are monumental in size and then come back to this, we think ongoing work is needed in standardization. So we think that's very important, and we're glad to see that activity from the stimulus. And then related to that is data is necessary but not sufficient. As I said, we have to make all of this useful. So improving semantics, understanding outcomes, making sure we report all that of that will enable the feedback in the loop to make this far more valuable, and that feedback will be valuable to any of us that provide information to consumers. Last chart here in terms of recommendations. So as I said, while we can go today with what we have, we want to see continued funding and development for standards in health information exchange. I think that as they get created and as they get used over a fairly long period of time, it takes a while for all this to happen. Gradually everything gets better and the systems will become more valuable. We want to see national connectivity. So I think that is important. As I say, we don't expect to be the only national connector through the PHR route. I think the enterprise systems need to connect to themselves. So we desire to see this national strategy for connectivity, and we desire to see that the incentives for that are clear. And I realize I'm not the greatest expert by any means in this room, but some of these incentives, what does meaningful use mean, et cetera, these are clearly complex topics and will need to be defined. Last but not least, what I do want to say is that I know all of us will be thinking a lot about privacy because we want consumer acceptance, and we must maintain the trust of the consumer in all of these systems. All of us, no doubt, mean well, but we must have trust, and we must do the things that preserve and maintain trust. The privacy discussions with respect to the PHRs are particularly complicated because they are, after all, the patient's information. So exactly what the system has to be able to tell the patient it will do, what it does for the patient, all must be documented, but ultimately it's up to the individual to decide what they do with their own data, and we have to strike that right balance between things. So with that, let me turn this over to our next speaker.
Just a couple thoughts, just a bit of reflections. Now, I have no paper in I have no PowerPoints and I have no published paper. And the other thing, I'll probably try to create a little bit more disagreement than just pure agreement, because I think these are really big subjects, and we have a absolutely generational opportunity in front of us. We are on path now for the delivery system in the United States to be absolutely automated by basically in the next 5 years, and it'll be ubiquitous. And we will have eliminated this pen as a device for medical as a medical device, because this pen basically is connected to the human memory, and physicians basically use these pens to create orders, and it's that order which launches and consumes, launches all those processes we've been talking about around either a diagnosis or a treatment plan, and it also, a medical decision by a doctor, basically consumes 80 cents out of every dollar consumed in our U.S. healthcare system. That's in the delivery side. So we are the generation, and I don't think we should waste that. So, and I don't think we should also not be a little controversial where there is room to debate and to improve our understanding. So what I didn't hear from anybody so far, you hear interoperability, but you don't hear how do we identify. We're the only country in the world, the Western country in the world, that doesn't have a national ID system. And I'm not saying we have to have one assigned by our government or governments, but we have to have a systematic way of knowing when we create this interoperability, it's the right person. Or we will create a new form of systemic error. And we're going the wrong way. So everybody wants to duck and avoid that subject, okay? And there are people in the room that believe that you can do it through an algorithm. just tag enough information about Neal Patterson, and I will be able to find your record. I mean, you guys are the best there is at basically crawling through data, creating tags and algorithms to find that match. That will be a mistake. Okay, so I just give you a little flavor. We shouldn't all be in agreement in this room, or basically most of us are unnecessary. So, you want me to go another one? Actually, I got a few things I want to say, but I think it's more important to create. So, we've got Google and Microsoft here on the panel, and we also have a law called HIPAA. Now, we're standing kind of on the shoulders. We're at this point with some convergence, and we're on the shoulders some really important stuff that actually allows us, I really think, to actually move forward here in the next 5 years in a big way. HIPAA happens to be one of those. Now, I'm not the biggest fan of people in this town making laws that we all have to follow, and I'm not the biggest fan of how HIPAA was actually implemented, but I think it was fundamentally correct to say it should be a crime to misuse my record, my information about my health. Okay? And so regardless of whether I consumerly enrolled it or not. So that's another good one, Susan. Now let me get to some of the things I want to say. And hopefully we'll get some questions later. So I've done we are the generation. I thought, quite frankly, I was going to miss it. But we are the generation that's going to basically completely automate, completely change the medium of which medicine and health is managed in this country. This is a big deal. Now, one of the things we're not hearing, and nobody is saying, is what it is we as a society want from this investment. This is a little bit like quite honestly, I'm an Oklahoma farm boy, okay? My great-granddaddy was 1 year too young to run do the land rush, but he sat and watched it. That was free land. So I feel like we're kind of at the Oklahoma land rush here again. Everybody's got their wagons. I mean, you can't believe how many people are coming out of the woodworks all of a sudden now become real experts in healthcare because they've got the wagons, you got the fast horses, and they're firing up. Most of these guys got huge offices here in town. This is the land rush, okay? But we're going to waste that investment. There's a lot of waste that's going to happen or could happen, and I think that is a shame because this industry we cannot afford to waste this. I think we're going to get one swing at this thing, okay? So we need to define what it is we're going to get from this, okay? What do we create? Now, I'm going to stop I think as a country and as a society, we need to have the debate, what is our healthcare system we want to leave for our kids? So we need a vision of that health system. But now one step below that is if we believe this is going to create systemic transformation, if we think this is the investment that's going to transform it, then let's be precise and specific about how we'll know whether it happened and the benefits of it to us as individuals, to the physicians, the hospitals, the healthcare delivery systems, and us at the government level, and us as employers who are still funding, and I suspect will be involved. So there's just a lot of stakeholders here that we need to know what's going to happen at the end. So, excuse me. Now, I'm not in Susan's journal, okay, because this is not peer-reviewed. So I'm an entrepreneur, okay? Entrepreneurs don't do research, okay? So there's I think it's outside. And I'm a big believer in don't oppose without proposing. So I try never to be against something. I try to be for something. And trust me, it's a lot harder to be for something. It's easy to take shots. And there's going to be tons of shots at this stuff, okay? So what it is that we want. So I really believe that we have the ability, and I call it the ABCs of systemic healthcare reform. This investment can create a change in the national healthcare expenditure in this country by $500 billion, an annual $500 billion savings. That is a big deal. The reason it's such a big deal is because we have not for 40 years been able to control – the cost of health care has exceeded the cost of the growth of the GNP for 40 years. We are consuming this industry through health care. Now, it's not necessarily a bad thing, but it is something that will totally can stop us as a country. And it's, for the record, every other country is at the same growth rate. We just happen to be ahead of them on the percentage. But they still, their health systems outgrow their economies too. So it isn't like somebody else has got this figured out. So what it is we want from this investment, I do believe can change, and I do the ABC. So we're going to automate, okay, and the automation has inherent efficiencies in it. Just take the paper out, and the processes and the workflows will improve because there's less friction in it. So there's studies that people have done that says, and that could be up to $100 billion a year, and these are recurring benefits. The second one is if we stop basing all the medical decisions based on human memory of the physician, which is what makes this dangerous is it's connected to human memory, and I think all of us in the room can write a small paper on what's the problem with human memory, okay? But that memory is what drives all it. If we base the decisions where evidence is available on evidence and where it's not available through consensus, what is the best practice, okay, we will drive variance out and we will drive costs out. There's another $100 billion there. The C part is if we can connect all the fragmented pieces in healthcare, all of them, okay, and that includes the pharmacy. You can't do it just through the integrated delivery system. Sorry. I mean, it's just a piece. You're just still a piece, okay? You're a big piece, Kaiser. Kaiser's a big piece. But so if we connect all of that, okay, we'll be able to coordinate care for the first time across all of the fragmented pieces. And that's another $100 billion worth of annual benefits. And the D part, okay, is the way we pay healthcare is obscene. The amount of friction in our healthcare commerce, just the way the commerce works. We all go to physicians' offices. We expect high-quality service. We're going to be critical as hell, and there will be a lawyer that will sue a physician if they don't perform correctly, provide high-quality service against the standard of care in that community. But then we walk out not knowing what we paid them, not knowing when they're going to get paid. That's ridiculous in today's world, the fact that we don't pay point of service. The fact that we even generate claims, okay, is a huge waste in the system. So there's $200 billion there to just redefine and change how commerce works in this system. We have more friction. It just does not make sense. You can go to McDonald's and take any card. You can go to any country, take a card out of your pocket and go to a machine and get cash in the local currency, and it is hitting your bank account. So there's huge benefits there. I just can hardly wait to get there. And the E part is every American should have their own personal health record. It's not a community-based record. It's not an exchange. Okay, we're not moving information around. This is my record, and it's available to any physician, anywhere, any country, anytime. It's available when I choose it to be available. And it's a person-centric, everybody prior to me, see, I don't think I've used the word patient yet. See, patient defines a relationship. We got to get the noun right or we're never going to get this discussion right. So everybody preceding me used the word patient. Who wants to be a patient in here? Nobody. We're all people. If it's going to be a national program, let's call us citizens at least. Don't call us patients. Okay? Now, patience defines a relationship I have. So we need to evolve to where there is a record. And I really think it's a big deal to have Microsoft and Google up here, and Intel and Dossier, because it is the beginning of a new era. The next decade is going to be really exciting. So I better land here, Susan. You're about ready to yank me out.
Thank you very much, Neal. Well, if this is the Oklahoma land rush, I guess we're a staging area along the way. Neal, thanks for giving us that analogy. Well, I'm one of the, I guess what you would call, Alfred used the great phrase, amateur expert. Many of us have had to become amateur experts in this field. So let me try to translate a little bit of what we just heard, and encapsulate some of the disagreements here. Essentially what we were talking about is there's some dispute here about what the underlying business model is going to be for this entire enterprise, and whether proprietary systems are going to have the ability to lock in the data, or whether the data is going to have free flow. That was one piece of controversy that emerged from the panel. We also heard that there are concerns about this direct potential tension between portability and privacy of the data. And then we also heard this discussion about are we going to have to get to, in order to preserve privacy, but also to have the data flow across all environments and pertain to the right human being, the right citizen, are we going to need a unique patient identifier, or can you get around all of that? So those were three of just the little points of controversy you probably detected in this panel. So we don't have a lot of time because we do need to move on shortly to the full-blown privacy panel. But let me come back to you, Peter Neupert, because you kicked things off. Are these in fact the tensions playing out among all of you competitors in different pieces of this business? And how is this going to be resolved from your perspective? And how are patients going to, or citizens, to take Neal's warning that we don't really want to be patients, what's the fate of American citizens amid all of this? Are you guys all just going to battle this out and citizens will wind up where they are? Or do we have, is there some potential for citizen control over what is going to happen?
Yes.
Would you elaborate, please?
I actually don't think there's so much competition amongst this panel. The competition is against the status quo. We've often said, I think Alfred and I, Colin and I have been on panels, Neal and I have been on panels where it's really the major issue is inertia. What choices should people make? How do we afford the investments? Farzad talked about skills. There's a whole host of barriers to adoption. Paper is the enemy, not the storage mechanism and not the electronic system of choice. I think disagreement's a good thing. I think people can differentiate based on different perspectives. I helped fund a study that Neal did about a national patient ID and the benefits that might accrue to the system. So as a software guy, he's right. Now, whether as a public we can accept that or not is another question. We picked a model for Health Vault where we avoided the question by enabling consumers to pull that information and using the sender of the information to do the authentication of identity, which they have to do anyway to provide service. Is it a perfect solution? No. Does it work? Yes. Would a national ID be better? Maybe. There's lots of countries that have national IDs that still have identification problems for patients, consumers, and doctors. So just having the ID doesn't solve the problem. The issue of privacy I'll leave to the next panel. It's really complicated. I think all of us on the panel have done the right things around personal control, notice and consent, clarity of communication. But it's a public debate that probably needs more communication. I always say we ought to look at the benefits, not just the risks.
Colin, do you want to respond to that?
Yeah, I just think it's, I agree with everything Peter said. I don't think patients, consumers, citizens, or whatever, fear competition amongst the people here. I think we're trying to figure out how to get them their information. So I just think it's axiomatic in this town particularly that nobody minds the answer to a question as long as you're asking the wrong question, right? And, we spend all our time getting our knickers in a twist over all the details of privacy and data flow and standards and all that kind of stuff. And that's, they're all the wrong questions. The right question is why can't we get data to individuals? It's a pretty simple question. I think we're all on the same side of that debate. What makes it easier? What makes it cheap? And for the most part, the barriers aren't technology. They're business issues and other vested interests. So, that's what we're trying to overcome generally.
Alfred.
So let me just address a couple of things here. Indeed, as a software person also, a nationwide ID would be helpful. I agree. These things get more complicated when you really look into them in depth into how you actually do it. But it's something that should be on the discussion agenda here. So I think I'm not afraid to say that. I don't actually know what Google's official policy is, but it should be on the agenda for discussion. I don't see why that wouldn't be true. Like we all agree on this panel on that one. So it's unfortunately not as controversial as you thought. I'm sorry about that. What I wanted to talk about, though, is this topic, though, because there's a bit of a tension. To what extent do we have to figure out the outcomes that are desired, figure out how to measure them, and understand essentially an analytic proof that we're going to achieve them before we begin? And then we'll certainly achieve what you suggested is we'll have a clear and directed and focused business plan for achieving return on investment for the taxpayers' money. The other side of it, though, is when is it valuable to be able to experiment and to say that we're going to try this, it's not very expensive to go do, let's try it, and we think it will result in better data quality because the data will be more scrutinized. And when should we try that? Because we think if we could measure this information and we could anonymize it and look at the results, enormously interesting epidemiological hypotheses will be so generated. And those could lead to breakthroughs, although we don't know what they are. We just surmise that there might be there. So I think we have this innate tension that's appropriate between the outcome-driven side of this discussion, and we've got to pursue that. But also, as Peter said, we have to look at how can we encourage risk-taking, bottom-up approaches towards things where someone builds a service that integrates into one of our platforms, and it might be very valuable and save an enormous amount of money and improve outcomes, but there's no guarantee that it will be. So I think that's a very interesting one. Just one plug, there's a National Research Council study that actually embodies this discussion within it. It was called Engaging the Computer Science Community in Healthcare Informatics. I was privileged to be part of it. And you'll see both aspects to it. On the one hand, the study says, how do we get the same kind of innovation in healthcare that we got on the World Wide Web and all these bottom-up startups that have generated sort of enormous economic value and excitement and really a change in society. On the other hand, the medical practitioners that absolutely and correctly observe that if we go install a new computer somewhere, by itself it's not going to improve healthcare. So I think that's this bifurcation we have to deal with.
Alfred, you just brought up the word research, and as we noted, there is $2 billion worth of research dollars available in the stimulus law. Neal, how should that be expended?
On the research side?
Yep.
I actually feel like a politician. I want to get one thing corrected. It's a subtlety. So I'm actually, the algorithm is what I'm against. So Peter, we need a systematic way of creating identity to move records. The healthcare historically has used algorithms to match and matches in that decrease, that increases errors the greater the population. So your method, so I don't know that it has to be an ID, national ID. Oh, I said we're the only major country that doesn't have one.
You got us all to agree with you, and then you get the other side of the equation.
I told you, disagreement is important. On the research side, I just think there is an unbelievable new platform that will come out for the ability to do research. It just always drives me crazy that healthcare is about the only industry that does not look at the empirical data that comes from their day-to-day operations and use it to increase their knowledge, mainly because it was paper-based. And in the paper world, it was like I describe. It's like sending the monks with candles into the cave to transcribe. The abstract is what we'd call it. Transcribe what it is the physicians and the organization did and what result did they get. And it was by candlelight the way it was recorded and then put into some Excel spreadsheet, or probably. So Microsoft got more license. So there was the ability to systematic, not only on the research, but on the surveillance. So I think NIH, FDA, and CDC, hopefully we can use this investment to create a transformational, we transform both all the way from creating new knowledge research, all the way including phase 3 clinical trials, all the way to surveillance. Is that drug really helping or hurting people in the population now that I got it beyond the 3,000 phase 3 trial? And really, I'm in phase 4, and I really don't know what's happened now that millions of people are taking it. I'm waiting for the adverse event report to come on a postcard. I mean, that's basically how the system works. And if we don't use this investment in this moment, and we be the generation to fix that too. So, you didn't say we were going to talk about that.
That's above and beyond the $500 billion you talked about.
We absolutely, actually it is. But so we have a lot to do as a generation.
Thank you very much. I'm very happy to be here, and also pleased to hear panelists in earlier panels mention privacy and the importance of protecting it. It's not at all unusual, actually, and this is a good thing, to hear the various stakeholders in this space talk about the need to protect privacy. It's the rare person who stands before you and says, oh, privacy, schmivacy, we don't need to worry about that. We've got that all taken care of, or what's the famous quote, privacy is dead, right? But where the agreement tends to break down is when you start getting to the level of the details. And really, for far too long, recently, as we've considered what we need to do to really facilitate the widespread adoption of health information technology, privacy was perceived as the obstacle to getting this done. Privacy is too hard. The issues are too difficult. We can't resolve them. Therefore, let's move forward with the easy stuff that we think we agree on, and we'll deal with privacy later. Well, one of the reasons why we felt it was important to become more active in this space and to write this paper is because, in fact, privacy is not the impediment. Privacy is the answer. It's the enabler. And just because it's sometimes hard doesn't make it critically important to deal with as we try to move forward on this. The reality is that the public appreciates what health IT can do for their healthcare. And in survey data, they want this. But in these very same surveys, they express significant concerns about their risks to health privacy. Surveys that were done in a largely paper-based world, which is actually where we still are today, show that about 1 in 6 people practice what we call privacy protective behaviors. They lie about their conditions. They try to hide their conditions from their providers by going to multiple providers or trying to pay out of pocket so that their care won't be revealed, and then the information used to discriminate them in employment or in insurance. So this is actually quite serious, and really the failure to deal with this is, in fact, the impediment. Privacy is the enabler, not the obstacle. But even if we clear that hurdle and fully understand and accept that we need to deal with it as we build these systems, it doesn't necessarily mean that we're all coalesced around the same answer. So what we put forth in our paper is that the way to build public trust, and public trust is really key to moving this forward, is through sound privacy and security policies and technical solutions. Technology actually gives us the mechanism to create stronger privacy protections than we have in paper, but it also magnifies the privacy risks. A box of paper records stuck in a dumpster outside of the office building doesn't reveal nearly as much information as the inadvertent touch that has 500,000 people's information suddenly out in the public view when it was whether intentional or not. I think that those are the realities that we have to deal with. So what we need is the next generation of health privacy. We had the first generation back during the HIPAA debates, but I think it's relatively widely acknowledged, with of course some disagreement, that HIPAA doesn't provide the complete solution to this new electronic world that we're building. So what we argue in our paper is that we need a comprehensive privacy and security framework that really sets very clear rules for the entities that are handling your health data about who can access it, how much data they can access, for what purposes, and then those rules get enforced and people are held accountable for complying with them. It's not a one-size-fits-all solution. The protections that you need in place for electronic health records held by providers and plans where the information needs to flow for certain reasons is not necessarily the right set of protections when you have personal health information in a record that's kept by a company that isn't a traditional healthcare player, that has a different business model, the protections really need to match, in fact, what the risks are, and then, of course, be enforced. It's not a solution that puts all of the burden or too much of the burden on the individual to figure out what are the intended uses of their information and whether it's permissible or not. We recently put out another paper that explores in a little bit more detail what the appropriate role of consent is in healthcare. It's a critical part of a comprehensive framework, but if it becomes the sine qua non or the anchor for privacy, it in fact ends up unfortunately providing very weak privacy protection because people don't always have the time to read privacy notices. I think you all need to think about the last time you signed up for something on the internet and actually read it rather than scrolled down and checked the box at the end of it. And I think we also need to remember the context that we're in, at least when we're talking about information flowing on the healthcare side of the equation, where people don't really have a meaningful right to say no because they need their care and they need their coverage. Situation is different with personal health records, which I'll go into in just a second. And this framework also needs to recognize, again, that the information needs to flow. We're trying to create information-rich healthcare, to borrow a Markle term. You don't do that by creating privacy solutions that box information up and don't allow it to flow for the purposes where we need it and want it to flow. At the same time, as we're creating these information flows, we need to make sure that those protections are in place to prevent inappropriate uses of that information. We all know how valuable data is. It's not just valuable for public benefit. It's not just valuable for my care. It also has certain commercial value. And again, if we're building public trust in the system, it's just that range of uses that we need to deal with, put rules in place, and enforce them. So what do we mean when we say a comprehensive framework, and what does it look like? What should it include? Well, absolutely, it needs to have core privacy principles based on fair information practices, which are the sort of traditional tenets of data stewardship that apply really across the board when you're handling personal information about people. I'll use the word people instead of citizens, so we get everybody. It also includes trusted network design characteristics. This goes to the point about how technology can actually help us protect privacy. In fact, the way we design these networks and the interconnections can, in fact, give us enhanced privacy and security rather than leaving the data more vulnerable, such as creating enormous unsecure databases, et cetera. And it absolutely has to include adequate oversight and accountability. If I could say, I think from a privacy advocate standpoint, where what we were most disappointed in over the years was really the failure on the accountability side. Whatever you thought about HIPAA good, HIPAA bad, at least having those rules better enforced is absolutely critically important. And, as for a model of what this common framework would look like, I'd really point you to the Markle Foundation's Connecting for Health initiative, who really have been doing a lot of work over many years with multiple stakeholders sitting around the table trying to pound out these very difficult questions that vex all of us. That's a model that's out there that we can rely on to build these protections. So what is that? How do we translate that from, here's what the common framework should include in it, to the reality of the fact that we're not operating on a blank slate? We do have a set of rules here, and that is HIPAA. So what does that mean? Well, to us, that means filling the gaps in HIPAA's rules so that traditional healthcare system entities and entities that are under HIPAA today or should be under HIPAA today, those rules get upgraded to match the challenges of this new environment that we're creating. But we think it's also going to take some new rules for these new players as data starts to migrate out of the traditional healthcare system and into the hands of entities that have business models where they want to help us take better care of ourselves. But again, where there needs to be a different set of protections to match what the risks could be to consumers in that space. And we put some very specific suggestions in the paper, and this was, of course, written before the passage of the American Recovery and Reinvestment Act. And so I think now it's a bit of a new day, and I think we have while probably some disagreement still among stakeholders about whether the provisions are good, bad, ugly, beautiful, we are now sort of past the hurdle of we can't do privacy. In fact, we can do privacy. We have set a foot firmly in this next generation, and now the task remains to build on that, through the regulatory phase that is inevitable with these provisions and additional considerations that are come up as this field really continues to innovate. So some of the specific recommendations that we put in the paper that did in fact get adopted include improving enforcement, and that includes giving states the authority to enforce federal rules, increases in penalties, making it clear that individuals can be held criminally liable for violating HIPAA, and tasking the Secretary to be a bit more assertive with their audit authority. The Secretary of HHS has always had authority to audit compliance with the privacy rule and the security rule, but that has only recently begun to increase. And rather than relying just on people complaining about HIPAA violations, we think it's important for the enforcement authorities to really be out there monitoring this more carefully. Extending HIPAA coverage to electronic exchanges, networks that are being built of healthcare providers to enable that information to flow, whether your care is being provided to you in Hawaii or here in Washington, D.C. These are really game changers, and I think we have only begun to scratch the surface of what we might need to really build consumer trust in having their information flow, both at a regional level and at a national level. But certainly this is a good first step. Tightening the rules around use of information for marketing purposes, this is really important. 77% of people surveyed are very concerned about having their information used to market products and services to them. But it's also a tricky question to address, because something that looks like marketing to you and me, maybe to my healthcare provider, looks like something that they're sending me to encourage me to adopt the right kind of care and to take better care of myself and to get myself into that gym more often and stop eating the chocolate cake. Examining HIPAA standards for de-identification. The de-identification standard, and I'm talking more about the safe harbor provision that has the requirement of the removal of specific categories of data. It's about 5 years, more than 5 years old now, actually. And given that the rest of the world and databases available to the public has evolved, I think it's completely unrealistic not to be continually examining this to make sure that standard is still robust and to make sure we have the right set of protections in place for when that data meets the de-identification standard. Right now, if it's de-identified, it's basically free game. And there are important uses of de-identification that need to be preserved. And so there's definitely some work, I think, that needs to be done there. And the Secretary's study of this takes steps toward realizing that. And then finally, ensuring electronic access by consumers to their records when those records are held electronically. This is already I had lots of folks come up to me during the conversations around the stimulus provisions and say, well, HIPAA already allows you to get a copy of your record in the form or format requested if it's readily producible in that format. So people were already interpreting that to mean if you've got an electronic record and you can easily send an electronic copy to an individual, HIPAA already requires this. Well, access to your own record is one of the top 5 complaints that HHS receives about HIPAA compliance. So there certainly was room for Congress to make it very clear that when there's an electronic health record in use, patients should be able to easily and cheaply get an electronic copy and to be able to send it to the person or the entity of their choice, thereby allowing people to direct their healthcare providers or their plans to send their information into their personal health record. So we made some good steps forward with ERA, but there's still some work to be done. I know one of the things we called for in the paper was really a re-examination of the category of healthcare operations, which today can take place without patient consent by HIPAA-covered entities. We've argued that the core rules around uses of information need to allow information to flow for healthcare purposes and those activities that are critical to accomplishing that healthcare goal. But I think if you read the definition of healthcare operations, it's hard not to agree that it's very broadly worded. And a lot of the tasks that today can take place with fully identifiable data maybe don't really need fully identifiable data to take place. HIPAA provides for some data anonymization options, but maybe it's not a good enough range of options to accomplish those purposes. So, we're hopeful that we can work with the agency to take a look at healthcare operations to examine that. It's not something that's called for in the legislation, but we'd still like to see it. And then protections for information in personal health records that are not offered by covered entities or business associates of covered entities on their behalf. We cover this in a fair degree in the paper, but there's definitely more work to be done, and it'll be the subject of yet another paper that we're already starting to work on. The consent piece is actually critical here. I couldn't agree more with the Google, Microsoft, and Dacia folks on the previous panel about these are consumer-facing tools and tools that we want consumers to use. If you can't tell them that they're going to have control over the data that goes in or out of that account, then game over. I'm not sure that anybody would be interested in using it. Having said that, we don't think consent is sufficient, for all of the reasons why it doesn't work that well in a context where healthcare entities are sharing your data. It also is not sufficient to put all of that burden on the individual. We're going to need an enforceable floor of protections. It's not HIPAA in our view, but it's something that follows fair information practices. And again, this is another area where Markle has done some really helpful work. We may even have some uses that we may want to outright prohibit, and it's not unheard of. Certainly in the Genetic Information Non-Discrimination Act, entities can't, employers and health insurance can't use your data to discriminate against you if it's genetic data, right? So that's a flat-out prohibition. It's not something that says, well, we can use your genetic data if the individual authorizes you to use your genetic data for employment review purposes and insurance. Sometimes some things are so important that it requires that extra step, and we're just actually beginning to explore that. And then the downstream, I call it downstream recipients. Maybe that's not quite the accurate word, but the real value in these PHRs is not the storage mechanism per se, but the potential applications, the health applications that patients may want to add on and layer on to that. And so just regulating the vendors of those records is not sufficient. You need to also reach those applications who are likely also going to be accessing and exchanging data with the patient, with the diabetes management service, if it's a diabetes management application. I mean, we have some things to think about here, and a whole infrastructure of rules that today does not exist, but that we think really needs to be built. What ERA, see, we're already calling it an acronym. We can't help but do this in healthcare. We have breach notification provisions that apply to these folks, but there's still some work to be done for a core framework of protections that would apply. So I will stop so I leave Deborah with sufficient time. But, the bottom line is that we still need this comprehensive framework. We have taken concrete steps forward to establish it. But let's say we've crossed one hill and we're looking at another one, which is maybe not quite as steep, but still is going to require some work by all stakeholders. If we recognize that privacy is important, and I really heard it from everyone here, it's really incumbent on all of us to roll up our sleeves and figure out how to get this done. So thank you.
Good morning, everyone. Susan, I want to particularly thank you for this opportunity to be here as a consumer representative. I think it's about high time that consumers were at the policy table, and I really come here as a consumer, even though some of you may know that I'm a physician of more than 30 years practice. I'm still in practice. I still see patients. I'm a psychiatrist and a Freudian analyst, and so I understand very, very well that no one would talk to me if they thought their information was going to be out on the internet. Privacy is absolutely essential to effective mental health care, and I learned about privacy from my patients when I first went into practice in, solo practice. I guess it was 1979. I learned really almost the first week I was in office about privacy from my patients because they came in and they said, if I pay you cash, will you not report my treatment? Will you not report my records anywhere? And I said, well, yeah, absolutely. And the reason people came in and offered me cash was because they'd already lost a job or their reputation had been ruined when information that should have stayed in the doctor's office did not stay in the doctor's office. So I want to say, in addition to that I'm a mom, and I am really optimistic about what technology is going to be able to do. I'm with you, Peter. Patient privacy rights, and I personally are very optimistic about what technology can do. And that's why I'm here. That's why I founded Patient Privacy Rights, and because I got kids. And so I've spent 30 years watching what happens to people when their information goes where it shouldn't, particularly to employers, particularly affecting jobs. And so how many of you all, I'm going to ask you to try to switch hats. How many of you have children? All right. How many have grandchildren? That's why I'm here. I'm here for my children and your children so that they will have the opportunities we have and that personal health information and genetic information isn't used to deny them jobs, credit, education, opportunities in life. And so let me just say, we really have a long conservative tradition of patient control over information, starting with Hippocrates. And you know what that oath said, whatsoever I shall see or hear in the lives of men or women which is not fitting to be spoken, I will keep inviolably private. Americans think that their doctors can keep their data private. They think that. That's why the secret, vast, systemic data mining, theft, and misuse of information has to be dealt with in order to have a trusted system. The Code of Fair Information Practices key privacy principle, is there has to be a way to prevent information about me that I disclose for one purpose to be used or made available for other purposes without my consent. It's control. And what you see on the screen is the definition that the National Committee on Vital and Health Statistics recommended to Secretary Leavitt in 2006. Again, privacy is the individual's right to control the acquisition, uses, and disclosures of personal information. So it's very, very striking and very, very critical to understand that everybody up here has been talking about privacy and how important it is, but we still don't have any agreement on the meaning of privacy. And in law, essentially the meaning is what you see on the screen. It means an individual's right of control. And if you're going to talk about consumer empowerment, that's the main power that consumers want in electronic systems. They want control over who sees and uses their data. I just want to, in your packets, in your handouts, I put a lot of information about the law and privacy rights in your handouts. Constitutional law, common law, there are physician-patient privileges, there are psychotherapist-patient privileges, and no one ever talks about what the law really says. There's a couple of key quotes. There's the Brandeis quote from Olmsted, that the right to be let alone is the most comprehensive of rights and the most valued by civilized man. You know, I'm really comforted by that quote because it's come to be accepted and understood. It's quoted everywhere. And Brandeis was the dissenter at that time. He was the dissenter at that time. We're the ones, Patient Privacy Rights and the Coalition for Patient Privacy, who have been the dissenters on privacy today. There's another quote in the packet from Sterling versus the Borough of Minersville in the Third Circuit Federal District Court from 2000. The constitutionally protected right to privacy of highly personal information is so well established that no reasonable person could be unaware of it. I mean, we have an incredibly strong consensus developed through over 200 years of law in this country in every state, and also in constitutional law. So I think that's where we need to start. I also have in that packet information about ethics. We do have ethics, research ethics, medical ethics, and they all require consumer-informed consent, as differentiated from blanket, advanced, and coerced consents, which are actually not legal. Okay, this slide I had to put in here. Some of you may have seen it before. This was the slide that really provided the foundation for the impact of patient privacy rights and our coalition on Congress, because we pointed out that at one time, when President Bush first took office and implemented the privacy rule, Americans did have a federal right to privacy, meaning control, through consent. You can read it in the second box. We call this 3 boxes. And then, in what we now see as part of the systemic prior administration's deregulation of consumer protections, that consumer protection, that right, was eliminated by unelected bureaucrats in HHS. And that's a fact. So we have to start with the facts. That change is what essentially legalized systemic misuse, theft, and sales of data. And, of course, that's in your handouts. And also in your handouts, we have the picture of what the results of that look like, which is a system with millions and millions of employees, of all sorts of stakeholders, being able to use, access, and do things with your data without your knowledge. Okay, what just happened? What just happened in high tech? We believe high tech was an historic privacy victory. And also handed out for you was a letter from our coalition. Patient Privacy Rights formed the Coalition for Patient Privacy in 2006. There are currently over 50 organizations from across the political spectrum that are members of the Privacy Coalition who have been working to put basic consumer privacy protections into federal law. If you look on the back, you'll see that 30 organizations signed this letter. The coalition today represents 50 million Americans. And in 2007, I think it was, Microsoft joined our coalition. In fact, they signed this letter as well, emphasizing the point that to have a trusted system, consumers really have to be able to decide where their information goes. So let me tell you a little bit about this process. We worked with the coalition to try to get the best protections we could into the bill, given the fact that, believe it or not, there were not enough votes to define privacy. It's amazing. And there were not enough votes to restore our fundamental right of consent, which we have in all 50 states, common law, tort law, constitutional law, and so on. But what we did get instead were some historic new privacy principles and rights. The first and the foremost and the centerpiece being a ban on the sales of protected health information with outpatient consent. Our coalition brought the fact of data mining and sales of data to the attention of Congress and the media, and they really heard us. So now, for example, every pharmacy is not going to be able to simply sell your prescription records every day without your consent. And we know where the data mining industries are going to go. They're going to try to claim that these blanket, advanced, coerced consents, you can't have your prescription unless you sign this, fly. And we're going to be right there with the FTC and the Department of Justice saying, No, that's not informed consent. Informed consent means voluntary, you have a choice, and you really understand the implications of what happens. The other second ask that we thought was really critical to get into the bill was a right to segment sensitive information. As you all know, the real privacy protections in this nation are at the state level for genetic data, HIV/AIDS, mental health. Sensitive data is protected primarily by the states. So this will allow the states to continue to innovate and legislate about data that their residents want to protect. We also got, finally, for the first time, accountability through audit trails. Now, these are not audit trails of every disclosure of protected health information, but they're a really good start. They only go 3 years. It's a start. We worked very hard, our coalition worked very hard to support Senator Snow's amazing work to ensure that you would get notified if you had breaches. The way that the bill was going to come out was, let me think about the right word. Oh, you would only be notified of willful breaches. Willful breaches. How many of those are there? Like 5? I mean, really? Most of them are inadvertent. And so we need to be. The fact that somebody made a mistake doesn't undo any potential harm. So she really fell on her sword to get meaningful breach notice. She essentially filibustered the Senate. And then, of course, Congressman Markey worked really hard to get encryption into the bill. And then we got, for the first time, consumers have the right to restrict the flow of some of their protected information in certain circumstances, not for treatment, but if I pay privately out of pocket to my shrink, there's no reason that information should go to a payer or to the healthcare operations of any entity. And the preservation of the therapist-patient privilege was in there. So we're in a whole new place where we have an administration that wants to restore the consumer protections that were eliminated, during the reign of deregulation. And one of the problems, of course, with ARRA that we're already seeing is many entities think that the protections don't apply. I don't know about the law, but the intent of Congress was to ensure that the protections covered the data in the places that exist. And so we can see from this that every time we try to draw a boundary, somebody's going to technically weasel out of it. So the truth is as Americans come to understand this system, we're going to have to make sure that protections are, first of all, meaningful, and second of all, comprehensive. If you simply move data to a place where the entity was never mentioned in a bill and you don't have the ability to control the use or the sale of that data, you don't have privacy. If you have privacy protections for 100% of the data only 25% of the time, you don't have privacy. So the only way to have a trusted system and not blow the $19 billion is if we require that electronic consent management tools be used where consumers can set their preferences in one place, not in an emergency, not under duress, down to the data level, with broad directives if they want, or very specific data level exclusions if they want. We need one place to set our tools. And then all of the holders of data, before they move data, not just PHR data, all data, need to check in with that tool to see if the data flow is okay. We need to have independent electronic consent management tools. That's one of the things that technology can really be innovative about, is there isn't any reason anymore for one-size-fits-all privacy policies or for blanket consents. And the other thing that I'd like to draw your attention to real quickly in the journal is the paper by David Kendall on health record banking. The other thing that is going to be required for consumers to trust the system is to have one place where they can accumulate all of their data. It could be very, very rich, could have alternative therapies, could have diet, could have environmental factors, could have exercise. So we could get an incredibly rich database for research, because the only people who can really make the data flow and gather all the data are consumers. And so Well, there's a whole lot more I could say. The American public has never been in favor of UPINs. Those work best for data miners. They don't serve the public interest. If you love what's happened to your Social Security number, you'll really like what's going to happen with your UPIN. It's a bad idea. It's unnecessary. And it's privacy destructive. So I look forward to the discussion, and we need your help. Patient Privacy Rights is a nonprofit. I take no salary. I never will. If you want us to keep fighting for your children's futures and grandchildren, I hope you'll sign up for our alerts and maybe consider giving us a donation. Thank you very much. Oh, and just about a week ago, Dr. Healy came out and talked about the need to do privacy now. Don't blow the billions without ensuring they're spent to build trusted systems. So that's it. That was a wonderful confirmation of what we've been working on for a long time, too. Thank you.
Good morning to all of you here. I'm delighted to be here. One of the things at this point is that I can't talk much about what we're doing yet because it's still going through deliberations.
Protected information.
Protected information, right. And also, not having a secretary yet, we look forward to having the secretary on board to participate in that. But I do want to talk briefly about three things. First, just give you a little background, set context, and then talk not so much about the specifics in the Act, whatever we refer to it, the Recovery Act, HITECH, or ARA, but some of the things that we really need to accomplish as we execute that. And then third, want to leave you with a few thoughts that I have about where this might really be going and addressing some of the comments that were made by some of the previous speakers. So in the remarks that I have, I'm really drawing on over 30 years of experience as a change agent, but then many of you also who are working in this field, who have been part of government or been part of industry and using health IT, are also change agents. Mine comes from both the training as a psychiatrist, a little different than Deborah Peel. I'm more on the biological side, doing pills and electricity. And part of that is that we go by the data-driven in terms of what's shown to be there, but knowing that data runs out long before the things that we do in healthcare. Also, as a parent, because all of us who are parents also are change agents in helping to shape the growth of our children. And then the other experience that I had, which was really quite unique, was being in the VA as it went through its transformation. And being in a system where your mother asks, why the heck are you part of that system? Because it isn't exactly well thought of in your hometown, to one that has now become kind of the model of how quality care is delivered. And being part of that change and knowing how painful that can be at times, but also how gratifying it can be, and the role of health IT there. As part of that change, Ken Kaiser, when he was taking us through that, had us ask a particular question, and it was, we had a phrase, patients first, kind of like patient-centered. He said, if patients first meant the VA goes away, are we ready to do that? Interesting question. Not that VA went away, but that VHA, the whole healthcare system, went away. And that really brought home, are we really embracing these phrases we talk about? And what does it mean to do that, particularly as a business? No problem making a profit as long as you're doing it and advancing the particular goals that we've all set out there and give lip service to, but do we really mean it? We are in a unique moment in time. We're perched, I would say, just past the tipping point, which means it's inevitable now. Speed isn't up very much, but we're starting to go down, and this is going to be quite a ride. We will be undergoing more and more rapid changes. And most importantly, as you've heard from many others, health IT is not about technology. And it's important for us to repeat it, but fortunately, I can reassure you that ONC, the HHS leaders, those who were there, and those who are coming, as well as the health reform officials, and especially President Obama, all know that that health IT is not an end in itself. It is an enabler of the kind of changes we want. And really, it's an enabler not of better health care. Yeah, it's that. But it's an enabler of better health. Better health for individuals, better health for communities. And I think that what we've been hearing in some of the earlier presentations, I'm going to make a little controversy, is that we're still stopping a little short because we're still at the boundaries of our institutions rather than thinking about what it is that we really want, which is more about getting to better health. And the phrase that we've used is it's about health and well-being of individuals and communities. And it's reflected in our strategic plan that we put out, that ONC put forth, which was meant to be basically neutral as far as partisanship. It was really laying out the things that we thought were needed. And in fact, that's one of the things that crossed. People were wondering in December, would it cross? Congress embraced it. The administration is embracing it. In fact, telling us we have to take that plan now, update it with a target that's now doubled in the same amount of time, instead of the majority of Americans, which means 50% plus one more, having electronic health records by 2014. Now it's all Americans by 2014. So that's been raised up. But the strategic plan does have two goals that are articulated. One is about person-centered. We do say health care in that. And it's about individuals and the providers having access to the information, but also those delegates or designees from the patients or individuals as well. And then a goal on population health, which is this aggregate information advancement of knowledge, advancement of our community health that covers a wide variety of things. And there were 4 themes that we applied to each of those. One had to do with the interoperability. One had to do with adoption. One had to do with governance, because we really have to figure out how to have a governance and a shared governance that involves all of us as stakeholders, with none being dominant, but all of us being a part of it. And the 4th was privacy, because we have to get privacy right. We have to have the trust there, or we're not going to be able to go further. And just as if we think about our experience on the Internet and when we decided to use that credit card, each of us had a different threshold. Each of us made our own decision. We need to allow individuals to make that choice, including deciding not to. But as part of that, we also have to make sure that those who want privacy get out of the way of those who want to have it shared. So that my 94-year-old mother, who is getting care from multiple doctors, if she wants her data to move, I want to help and contribute and join you in getting that system that will allow that information to flow seamlessly when she wants it. Now, about the HITECH Act, one of the things that, in reading some of the papers and some of the commentaries that were on the web, there was concern that it didn't specify that information was supposed to move. If you look at how Congress constructed that, it actually was very powerful because they allowed a flexibility. They didn't over-specify. They gave us tools by which we could make the choices. And one of those was the issue of meaningful use, which, along with qualified record, certified record, and a few others, that comes out as part of the sausage, still gives us some real power to be able to drive this. Now, we know that the stimulus bill, for the most part, is to create jobs, and the health IT, the high-tech activity, will be part of that. But it's also tied to the health reform. And so while we're beginning to put things in place, it will be aligned with the health reform, because $2 billion plus the $17 billion estimated incentive is a lot of money. It's a huge amount of money, especially when you have a $60 million a year budget before that. But it's still not enough to get us there. And in fact, it would be very easy to spread that money evenly across the country, and it would just disappear. And we have to make sure we don't do that. We have to make sure we take every one of those dollars and we get $10 of impact for every dollar we spend. And that's the challenge we have on our plate, and we need to work with you to make sure that we are able to get that type of outcome. And it is about outcomes. It's about the quality, increased quality, decreased cost, increased convenience for each of us as individuals on the healthcare side, and allowing business models that can make a profit if they're doing good and moving the data on that behalf. Now, there are 4 things that we need to be able to do. One is we need to be able to have an impact on the standards. We've heard a bunch about the standards and interoperability. And that's going to come from iterative use of those standards. Prior to now, we didn't have a network, so you had standards, but you couldn't test that. We now have the NHIN, the NIN. A number of you here in the room were part of that effort and activity, and in fact, it allowed us to iterate and begin to develop and show how those standards could be really useful. We have to get beyond the cottage industry in order to move it. The standards have to be sufficient to move the information, but we can move the whole record. And if we can move the record, even with the things that are not standardized, then we can get to other things that we need, such as vendor independence, being able to move a record or switch vendors. Oh, but I can't do that because the interface is different. Well, there are ways of having the interface so the provider can take that with them to any system. So really providing a way that's actually safer, because now the provider knows that system and isn't looking for where the issues are. And there was a report from National Research Council that talked about that. We need to be able to also obliterate the disincentives for exchanging health information, because right now, as we know, the disincentives are there, and if we can break through, kind of punch a hole in that dam, then there can be innovation about moving forward and exchanging real information. And that's going to come not only from the high tech, but also from health reform. A third thing that we need to do then is to move forward in the quality reporting, and you'll hear more about that, I'm sure, from John later, because we need to see what that quality is and report on it. And fourth and most important, we have to unleash innovation. The things we do cannot lock us into the current system. It really is about real transformation. And that's unleashing innovation not only in IT, but in the healthcare delivery models. Because as an enabler of change, IT is really disruptive to the status quo if used correctly. And the resistance will come from some unlikely sources, not only those who currently are the individuals who are on top of the current system, but interestingly, at least in VA experience, as we move forward, it was from those who were initially out front, who suddenly didn't understand how they were overtaken by another wave and thought that their particular way may be the way forward. So there are some interesting opportunities and challenges that are going to be there. And because the course is uneven, it's not smooth, there will be fits and starts, and there will be some failures along the way. And in a political environment, are we going to be able to be allowed to go through that? A natural thing in an industry, think of the .com, where some people thought you'll never make a profit on the web. There are a few of you here who now know that you do. But we're going to have a couple of those along the way, and we're going to have to see how we go through it. And finally, this is personal. Whether it's about our children or our parents, all of us are recipients of the health care system and about our health and the health of our children. And dare we talk about the real transformation, which is not about making the health care system better and more efficient, but about going beyond that. And it's about health, not health care, not illness care, which is really what we talk about. It's about health. It's about not how to manage the chronic illness, but how to control it, which is what we're starting to do, how to prevent it, and how to predict it, and getting into the genomics of the future. So really, it is talking about the health and well-being. It's talking about some things that would be very exciting in the future as we get into it, such as social networking, and whether, in fact, things such as obesity, as has been reported recently, has a network effect, and whether the Facebook and MySpace and Health 2.0 approaches of our children actually will be what will teach us about how we achieve health using all of these health IT tools. look forward to working with you and all of that, and I think it's got quite an agenda ahead of us and quite an opportunity. Thank you.
So I'll be very brief. First, because all the smart things have been said. Second, because I'm not an expert on IT. I am a member of Kaiser. I am a father. I am a doc. I'm not a shrink. I have a shrink, but that's more information than you. So, I too want to say three things, but I have to begin this because Susan knows every time I come to Washington, I say, I bring you greetings from California, and health care must be what?
Cheaper.
Cheaper. Thank you very much. Everybody here today has talked about value. Value is something that providers say they want when they don't want to talk about the price of the thing. So I'm here to say it should be cheaper, and that's part of what we have to talk about healthcare IT doing. I'm going to talk about three public policy issues that if IT is not mainly about IT, the promise of IT is not mainly about the public policy issues in IT, but the other enabling public policy issues. And while I do that, I want you to think about three companies: Amazon, Travelocity, OpenTable. Everybody here knows all three of those companies, all right? So the first public policy issue is reimbursement. Louise Lang told you that in Hawaii Kaiser, primary care visits had dropped by 26%. For Kaiser, that's great. For most doctors, that's a disaster. That's a financial catastrophe. And as long as we pay people in healthcare to produce visits, we will continue to obstruct the diffusion and use of IT to do the things it ought to do, which is to stop silly things like visits when they shouldn't be happening. So unless we can, as we proceed on the IT policy front, proceed on the front of reimbursing someone, some entity, some organism for the longitudinal care of a group of patients being responsible both for their clinical and financial status, the capacity of IT to unleash us from the paradigm of the visit, the tyranny of the physical interaction, will be obstructed. So reimbursement is the first thing we've got to work on. The second thing we've got to work on is comparative effectiveness. Now, we're going to hear from ARC. I got to tell you, I'm a lapsed health services researcher. Let me tell you what the incentives are if you're an academic health services researcher. The incentives are for you to get as big a grant as possible, for as long as possible, to hire a dedicated staff that does nothing but your research project, for which when your research project is over, that staff disappears, leaving absolutely no impact on the delivery system whatsoever. That is what your incentive is if you're an academic health services researcher. I am not so naive as to believe that some portion of the comparative effectiveness money will not go down that chute. But please God, we've got to develop some mechanism by which, as you heard, we develop a data system in real time that actually works off the same data system by which people care for people and pay for that care, as opposed to building standalone, dedicated, isolated research data streams which cannot be supported and cannot be afforded. So the key task, if IT is to bring its promise to bear in comparative effectiveness, is to break out of the paradigm of standalone, dedicated, research-only data streams to build the same kind of data streams for which every other business in America works. Linda Dillman from Walmart once told me, we know more about a can of cornflakes, a box of cornflakes that we sold in some store outside of Portland. We can tell you who bought it. We can tell you what else they bought. We can tell you what they're likely to buy next week. We know more about that than you know about a patient you've been seeing for 10 years. And it's true. There's no data research project with nurses with clipboards running around. So comparative effectiveness is the public policy thing that's got to be gotten right if IT is to fulfill its promise. And the last thing that has to be gotten right is the maze of regulation that protects the incumbents in healthcare. Now, I asked you to think about Amazon, Travelocity, OpenTable. Amazon is not Kramer Books with a computer. Travelocity is not your local travel agency with a broadband connection. These are service platforms that are enabled by IT but would not be possible without it. Do you understand what I'm saying? They are new things in the world. What I'm suggesting is that the real promise of IT is to create in healthcare new things in the world. Not simply to wire the incumbents to do what they do more quickly. Now, that would be a good thing, don't get me wrong. I understand that's important, but if we limit our IT to the interests and perspectives and capabilities of the incumbents, that is to say, if our definition of meaningful use or our demands for interoperability have to track the capabilities of the incumbents, then what we'll be doing is giving Kramer Books a computer. Now, I've been to Kramer Books. God love them. It's good for them to have computers. It's good for small independent family docs to be wired. But the promise of IT is to bring us forms of service that we can't even imagine now. In the same way that healthcare has to be what, Susan? Cheaper, thank you. In the same way that we now do for ourselves in our banking life, in our news acquisition life, in our travel life, things that would have been unimaginable 15 years ago, enabled by IT, things that 15 years ago would have been foolhardy, dangerous, and for which travel agents and stockbrokers would have told us we were taking our lives or our portfolios in our very hands, we now do them without even thinking about them because there are new things in the world enabled by IT. So what I'm suggesting to you is it's important that hospitals be wired. It's important that doctors will be wired. We will need them for the foreseeable future. But it's also important that our public policy consider scope of practice laws, corporate practice of medicine laws, the entire range of regulations that constrict the development of new things in healthcare, always waving the bloody flag of patient safety. Because if the promise of IT is to help make things cheaper and more responsive and more accessible to people, then as in other industries, we've got to allow for the development of new services, new organizations, new platforms whose configuration we can only vaguely imagine right now. So those are the three public policy things that we've got to get right to get IT right. We've got to get reimbursement right. We've got to get comparative effectiveness right. And we've got to get regulation right. And the last company I mentioned was OpenTable. OpenTable is an interesting example. Anybody here ever use OpenTable? So OpenTable has brought Kaiserness to non-Kaiser docs. It's allowed you to get the capacity, the sophistication of a Ruth's Chris or an Olive Garden as an independent restaurant. So part of what we need in IT, for those of you who are here for the land rush, I know you're here. I know you're here. It's the land rush and the gold rush and the GI Bill all rolled into one. Because I'm sure Epic's in the house and eClinical Works is in the house and Cerner's in the house and NextGen's in the house. Y'all are here. Someone is going to be able to bring to smaller practices the capacity that they need to be interwoven with the rest of the world without necessarily joining the Permanente Medical Group. There's a model in OpenTable about how to do that. So my plea to you is to think not just about the public policy of IT, which Lord knows is important, but to also think about the other related public policy areas that are necessary to get right if IT is to fulfill its promise. Thank you.
I'm going to actually make a lot of the same points, but come at it maybe more from the IT perspective. And many of the points that Mark made translate into the issues that I think are critical in IT. I have 4 basic points to make. One is that the world as we know it of health IT has changed, and we have to get it right. The second is that getting it right means that trusted health information sharing is used for measurable health improvements. In fact, I would change the title of this conference from Stimulating Health Information Technology Adoption to Stimulating Health Improvements, maybe in parentheses, with health information technology adoption. The third is that rapid innovation is essential, and I wholeheartedly agree that there is a new and pressing need for new services and new technology uses that make care better for people. And that's critical. And then the fourth point, which is the topic of my paper, and I will talk about that, is that there's a new demand now for assessing population health, comparative effectiveness, and boy, the way we approach it, I couldn't agree more, better be about making good decisions at the point of care for patients and providers. So let me start with the world has changed. I think now more than ever, if you believe nothing else, you should believe that there will be an unprecedented demand for accountability. That following this public investment in health IT, there will be a significant and heightened demand on the part of the public, policymakers, to understand what we got for this investment. And I think the President said last week at the Health Summit that there is an economic imperative now to deal with health reform. I think real reform, as Mark said, will depend on the appropriate use of information to make better decisions at every level. And for that, we do need health IT. But the changes that I think the Recovery Act portends for health and health IT must consider this new opportunity thoughtfully and carefully. And an openness to change, a willingness to rise to this economic challenge, a challenge of our time, is not a criticism of past efforts. It's an imperative. So with that, I would say that this massive public sector investment will create scrutiny and demand for accountability to show that these investments respond to the crisis at hand, that they ramp up a nascent health IT sector, and that they really achieve the quality improvement and cost reduction objectives of the law. That is what's at stake. In short, we must get health IT right, and that all of our old assumptions for what we need to do now may no longer apply. Health IT investments, first and foremost, have to be used to improve health. And this has to be the goal at the outset. Technology by itself, and I have coined this term in one of the previous health affairs papers I wrote, we cannot imbue magical thinking to technology. Technology is a tool. It's designed to achieve an objective. If you don't tell it what the objective is, it doesn't get there. Okay, my second point. So what does it mean to get it right? It means that we have trusted information sharing for health improvements. And when I say health information sharing, I'm talking about everything from a personal health record to an electronic health record, however, a browser that gives you lab results. However you get down to it, making a better decision for both the patient and the doctor means using information. And not just the information you might have in your medical record, because we know for the most part today, people don't see one physician anymore, particularly when they have chronic conditions. Care is scattered. And most of the errors, most of the opportunities to improve care are errors of communication, errors of misinformation. And technology is really good at those things. So we have to enable it to do that. The way to achieve it, however, the way to achieve improved health and information sharing, I'm going to argue, is not by standards regimens or certification as proxies for health improvement. Standards are important, yes. They are very important. But the way to achieve real health improvement and appropriate health information sharing for this goal is about setting the goal. And then the standards and the technology need to be implemented to achieve that goal. I say this for two reasons. The first is, while protocols are created, standards are adopted. They are not created. A standard becomes a standard when it's a standard. And what I mean by that is it's used. And history of standards is rife with perfect standards that were worked out on paper that were never adopted and that never met the true test of a standard, which is how it's used and adopted in the real world. The second reason I say this is that information won't be shared until there is a compelling reason to do so improving healthcare, and until the parties that hold the information trust each other. So it seems obvious to people sometimes when we talk about standards that creating a set of standards must remove the obstacle, but it never happens this way. Standards are incremental. Of course, we need a basic set, but if you look at the internet as an example, the most widely adopted standards ever globally, they evolved over decades, and they enabled primitive tools at first, and then through use and new value and services, those standards evolve. Accelerating standards adoption is about creating the right goals and creating motivation to adopt those goals. I think there's a historical opportunity to get health IT right now, and I think some of the issues around incentives and why information isn't shared have already been discussed. Suffice it to say that many of the failures in the system, as Mark much more eloquently said, require people to invest in infrastructure to reduce unnecessary or redundant care, not to be in their best financial interest. And until we address that, placing a value on high-quality health improvement goals, we're going to continue to struggle with this issue. Technology alone cannot fix it. So I think the path ahead is incremental, that it starts with the basics, and that I'm going to argue that being able to share and being motivated to share even unformatted, unstandardized data that is critical for the right decision to be made for a patient is better than perfecting data that is never shared. Okay, trust. I talked a lot about sharing. Let me talk about trust. There's been a lot of discussion about privacy and the importance of it, and an amen to that too. We've done a lot of work on this, that as has been mentioned. But I think what's inspiring about the new law when it comes to this is that it seems to have been written in a way that recognizes that you cannot uncouple technology and privacy, discussions about privacy and how information is used from discussions about technology. We've long said in Connecting for Health, decisions about standards and architecture are, in fact, de facto policy decisions if there are no policies to guide them. And so I think coupling those is really important, and that recognizing that discrete work on technology with policies thought of later is clearly something we should learn from the past, not the road to go down. Third, rapid innovation is essential. There's been a lot said about this. I think Jim Walker, Peter Neupert, and Bill Stead in the National Research Council report said this, and Mark said this today also. Today's tools are not our desired destination. They are a start, but this public infusion of capital is a real opportunity to stimulate innovation in tools and processes that improve care, and we are not only about optimizing transactions, and I hope we don't squander this important new opportunity. My fourth point, and really this is the topic of the paper, and that is really about addressing this new demand for assessing population health improvements and demonstrating results, comparative effectiveness research. They have to be about making better decisions. And in the paper that I wrote with Farzad Mostashari and Clay Shirky, we talk about sort of the pervasive paradigm today for whether you look at health services research or quality or population health, public health, has been to try to identify the question, collect all the data from all the disparate sources, clean all the data centrally, analyze the data with that research staff you hired with the grant. And unfortunately, the people in the best position to make use of the findings of that research and information don't have easy access to it. So it's a real shortfall. It also, of course, is a privacy risk, right? Because all these redundant collections of identifiable information for all these purposes creates exposure, whether we like it or not. But the failure is not just of privacy, it's also a failure of results. We have not successfully been able to have and build an evidence base about what works and what doesn't for critical treatment modalities. So in the paper, what we talk about is what is emerging as a more distributed approach. The way I like to simply describe it is to say, rather than always assuming we have to bring all the data to the question, we should think really hard about using modern tools to send the question to the data and leave the data where it is. And I think what that also does is it creates this critically necessary feedback loop for the user. Because today, when you fulfill your responsibility as a provider or delivery system, sending all your data to the reporting entities who are asking you for it, you don't get anything really out of it. I like to call this you send your data to the mountain, but the mountain never sends you anything back. And I think we really have to think about bringing that kind of information and decision-making capacity closer to the people who are in the best position to make the right decisions with it. And that's another reason that argues for a more distributed approach to this. We highlight a couple of examples in the paper, including the distribute model for flu surveillance. This, again, rather than trying to collect all the data that you might be able to derive who has flu from, Farzad Mostashari in New York City really developed faster, better, cheaper way of basically saying, hey, you know what? Just tell me if you've got flu. If you're a hospital out there, just give me your counts. And quickly was able to develop a picture of national flu surveillance that quickly surpassed the longer road we've been down. So I hope that we take these examples as instructive as we contemplate how to address the need for accountability that this new law creates, and for health reform. Thank you.
18 months ago, Dan Gillen and I went down to John Eaglehart's office, and we said, you put out a really great issue of Health Affairs in 2005 on health IT. We're thinking that another one for early 2009 would be a really good idea. And he said, yeah, I think that sounds like a good idea. Had you said to us at that point that this would be the context in which this came out, I was kind of hoping this would be informative as, legislation went ahead and, that's gone, that's done. So it's an extraordinarily well-timed issue. Everybody has already said that their North Star is better health care. Now, whether that's cheaper health care or whether that's more effective health care or, you name it, it's better health care. It's not about the IT. So enough said on that. It is also now given that implementation is going to happen. We are holding on to the handcart desperately as we rattle down these tracks. Okay, so implementation is going to happen. I am going to strongly advocate to you that it be accompanied by sober, robust, thoughtful, and ongoing evaluation. Okay, this is where AHRQ has been for a long period of time, as well as a number of our other colleagues, both in the public and the private sector. It is so important to get this right, which means that not just that we put all the good thoughts in up front, but that we continue to think about it as we do it, and that we hold that North Star of better health care as the standard to which we are judged. And I will privately, not in my public role, but I will probably pray that we have the intestinal fortitude to do mid-course checks and make sure that if we are not doing what we thought we wanted to do, that we can make mid-course corrections, both for myself and my children, as everybody has said. I can point with pride and my ears, my eyes well with gratitude at our colleagues who are out there who are ready to help us down this path. I was going through the issue over the weekend, and all of a sudden I realized, and I went back and counted, that 6 out of every 7 articles was either written by somebody at AHRQ or by somebody who's been funded by AHRQ, or they reference something that was funded by AHRQ. And I say that not because I want to say, ooh, look at all the great stuff that we funded, but I say it to point out to you that there is an extraordinary cadre of people out there ready to take this on, and you've seen a lot of them up here today. Okay, and yes, they have a lot of different ideas, and that's great. Okay, we're going to have a really robust conversation about this, but they're ready to do it, and they're ready to move ahead with it. So it's going to be rough. It's going to be rocky. It's going to be fast, and things are not going to turn out perfect. But we're going to go down this road, and we're going to have great people with us at the side, and hopefully we're going to be able to do the right things as we go along. I am not going to touch payment. I am not going to touch regulation. But for the Reverend Smith, I will offer the following advice. Get thee to a nunnery. And in this case, the nunnery I want to offer to you is the Institute of Medicine is having a committee that is going to be gathering public input on comparative effectiveness and how it moves forward. So, good message. I need you to carry it one more place. And that's going to be important in how the comparative effectiveness work proceeds. So with that, I thank you very much.